So a very good afternoon and a warm welcome to all and one who has joined in for this 5th edition of Endocrine Enrichment program. The program began about 5 years back. It was mainly due to the vision and enthusiasm of Professor Shubhankar Choudhury, who also happens to be the course director of this program, that it took shape. And as I said, we are in the 5th edition. So after taking some baby steps, we have now reached the final year of preschool. We'll be joining primary school from next year. But even at this point of time, we have grown over the last few years. This year, we have received 135 registrations, student registrations from 36 different institutes teaching DM or DNB course in endocrinology. And before taking you further, I would also like to introduce myself, as I'll be there in the background helping the conduction of the program over the next 2 days. I am Dr. Shoumik Goswami. I'm the faculty at the Department of Endocrinology at NRS Medical College, and I helped Professor Shubhankar Choudhury with the organization of this event over the past 5 years. Now, as I said, we have grown in numbers, and I think it's not only in terms of quantity, but also in terms of quality that we can ensure that over the next 2 days, we'll have good academic discussions. We have the brightest young minds in endocrinology with us. And of course, we have the most renowned and reputed and respected examiners in India with us to take us through different case discussions over the next 2 days. So I now ask the technical team to help us with the ceremonial lighting of the lamp. Any auspicious occasion in India customarily begins with the lighting of the ceremonial lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रः.
So thank you. We now move over to the formal inauguration of this year's Endocrine Enrichment Program, the 5th edition, 2022 edition of EEP. And I request our course director, Professor Shubhankar Choudhury, to share his words of wisdom with us and declare this event open formally.
Thank you very much. Very good afternoon, good evening to all of you, our young friends, the DM and DNB trainees from across the country, and the very senior faculty members who have kindly consented to join and allowed their students also to join this program. As has already been mentioned, this has been growing in strength. Hopefully, it's helping our students to become better endocrinologists overall, and in the short term to face their exams more efficiently, more effectively. I hope this is a good year for all of us. I mean, whenever we say Happy New Year, this year many people would retort and say, what's so good? There's rampant COVID all across the country. But of course, we have the silver lining in that with the current variant, at least the severity of the illness is much less. But the numbers are, of course, very huge and are likely to grow further. And I must say, if you can have a quick survey amongst all the participants today, I would feel possibly at least 20%, if not more, would be positive, but still may still be able to, are able to participate in this program. So that's the good thing that we can look at, and we can hope that any future variant or only makes the virus more akin to a common cold rather than a more severe respiratory illness or multisystemic illness. So a few ground rules for this program. For each presentation, for each examination case, I'm sure there would be designated person to present. And I see Dr. Bipin Shetty. Good afternoon. I thought you said you'll find it difficult to join early, so we had put you towards the end of this evening. But thank you for joining and giving us the further fillip to this program. So one person would be presenting. By and large, the examiners will try not to interrupt during the presentation. Unless there's something very compelling, then of course one could ask for clarifications. But this presentation part should not be too prolonged so that we can have a good interaction at the end. And while it's for each case, there are two examiners who are allotted officially. Any other faculty member who has already or is there, has joined, could also put in his or her question or viewpoint. And eventually, all the other participants could also put in their points. So these are the few ground rules. And we have, as usual, as in the previous years, we have at least two competitive sessions. So one is the Endocrine Wise Owl, which we'll be having tomorrow to assess our ability to critically evaluate scientific papers. And we have also learned in the last 1.5, almost 2 years, that all that comes out, even in reputed journals, even in NEJM, cannot sometimes be taken as gospel truth. So we need to have our own brain mechanisms sharp enough to take the best possible understanding from each paper. So that's why I think it's very important that we develop this skill as well. The other, of course, is what we have been having, the quiz session, the Hawkeye, the Endocrine Hawkeye, which has been a hit right from the first edition of this program, which we will be having this evening. And that apart, we have usually 1, 2, 3. Initially, we were having more sort of lectures or talks, but then we found from the feedbacks provided by the participants that they would like more case to be discussed and less of talks. But this year we have only one such talk by sort of amongst the most senior endocrinologists amongst us, Dr. Professor Anil Bansali, and he will share his vast knowledge and experience and wisdom in discussing common errors in managing diabetes. So with these few words, I welcome all of you once again to a day and a half of learning, hopefully learning through fun and trying to sharpen your skills at various aspects, including how to appear for your exams, DM and DNB. So all the best to all of you. And once more, my sincere thanks to all the members of the faculty, senior members who have joined in or will join to help the cause of our students. Thank you very much. let's try and go on to the main part of the program.
Thank you, Professor Shubhankar Choudhury, for those kind words. And of course, as you said, we will have the next 8 hours of pure academics, pure learning, and there will be contests thrown in as well for our students. As is customary with EEP, we will have case presentations, and the person who presents the case will sort of have some immunity against being asked questions first. That person who presents the case will be asked questions only if others in his or her group has failed to answer the question. And I will request everyone to participate, everyone who is there in the group to participate, because this is just a mock examination. The more you answer here, the more questions will be asked. We can go through the sessions rapidly. The better will be our learning, more diverse will be our learning. So without further delay, I request Dr. Yashashvi to take up the first case presentation. And the examiners for this case, again, all our examiners are reputed examiners. They are renowned, respected examiners across India. None of them need any formal introduction. For the first case as examiners, we have Professor Mala Dharmalingam from Bengaluru and Professor Shubhankar Choudhury from Kolkata. I would request our examiners to join as well. They are both of us are there with us. And I request Dr. Yashashvi. Dr. Yashashvi is presently a postdoctoral trainee at the Department of Endocrinology at NRS Medical College, Kolkata. Over to the examiners to take us through the first case presentation and kick off the academic proceedings for EEP 2022.
Chomik, can we have the names of all the participants in this session?
So if you give me a minute, I'll tell the names just right away.
And who can tell us how many of them have actually joined?
Can someone from the back-end team tell us how many of them have actually joined?
Right, I can.
11 have joined, so 11 have joined.
So what's the total number? 15?
22 is the group size, sir. 11 have joined. We are chasing the other 11, sir.
Right. So it's a full cricket team. And we have
the names have been given, sir, in the chat. Chat box.
We've got the names. Yeah. Okay. Thank you. So we could start, and it's Indigo before time departure, 3:59. Yeah, let's start.
Thank you, sir. Thank you so much. So I'll just share my screen also. So is my screen visible?
Absolutely, and you're audible as well.
Thank you so much, sir. Good afternoon to all the respected teachers, examiners, and my dear colleagues. I'll be presenting the first case for this year's EEP. So a patient, Mr. Ashok Singh, 48 years of age, resident of Howrah district, married and a tailor occupation, presented to us with complaints of protrusion and redness of both eyes for last 1 year and diplopia for last 7 months. History of presenting illness. Patient was a known case of thyroid disorder for last 4 years and was admitted to us with complaints of protrusion of right eye which started around 1 year back, followed by left eye around 1 month later. The protrusion was insidious in onset. It was associated with grittiness and foreign body sensation in both eyes. It was also associated with redness in both eyes, which started at around the same time, and also there was swelling around the eyes. Patient also complained of pain in eyes on movement, but not at rest. It was associated with excessive watering from both eyes. Initially, it was not associated with diminution of vision, but for last 1 month, patient has noticed some decrease in distant vision, not very significant, but he complains that there's some decrease, but there is not any decrease in near vision. There is no history of impairment of color vision, and there is no history of any complaints of suggestive of ptosis. Patient also is complaining of diplopia for last 7 months, which was also insidious in onset, initially intermittent, which was present mostly during the morning hours, but now has become constant. It is more on looking laterally and improves on closing one eye. Patient is also complaining of deviation of right eye inwards and upwards for last 1 month with difficulty in moving the eye laterally. Patient was diagnosed as a case of hyperthyroidism 4 years back when he presented with complaints of tremors in both hands, palpitation on exertion, and increased sweating. He also gives history of weight loss, which was not documented, but he said that his all clothes had become loose and it was associated with increased appetite. History of heat intolerance was also present at that time. There was no history of increased stool frequency, no history of any significant neck swelling, dysphagia or dysphonia, no history of any hypo or hyperpigmentation of skin, no history of swelling or redness over legs, no history of any postural dizziness, no history of muscle weakness or bone pain or fractures, no history of gynecomastia or erectile dysfunction. There was no history of any jaundice, dyspnea, fever, pedal edema. Treatment history at diagnosis, patient was started on tablet carbimazole 20 milligrams thrice a day. After starting treatment, patient's initial symptoms gradually improved. Initially, he underwent regular thyroid function tests every 6 months and the dose was gradually brought down to 30 milligrams per day in divided doses. However, following this, patient did not get tests for a year but continued to take 30 milligram carbimazole. Patient then developed ocular symptoms and was then referred to a hospital for the first time. Patient was first admitted in July of 2021 and has since received a full course of IV methylprednisolone as 500 milligram weekly for 6 weeks, followed by 250 milligram weekly for next 6 weeks. Ocular symptoms did not improve and there was slight worsening of distant vision. Patient was then given high-dose pulse methylprednisolone 500 milligrams per day for 3 consecutive days. Patient said that there was some improvement with diplopia. However, he still had clinically active disease and patient was then given injection rituximab 1000 mg, 2 doses 14 days apart. The last injection that he was given was just 4 days back. Currently, patient is on tablet carbimazole 10 milligram once a day. Patient has no past history and is not of any chronic illness and he is not a case of diabetes or hypertension. Patient complains of reduced sleep, appetite is normal, bowel and bladder habits are normal and he is not a smoker. There is no history of similar complaints in the family. Coming to examination, general examination, patient has a pulse rate of 88 beats per minute, regular rhythm, nominal volume. Blood pressure is 120 by 80 millimeters of mercury, right arm supine position. Height is 163 centimeters, weight is 69 kgs with a BMI of 25.9 kg per meter square. There is no pallor, icterus, clubbing cyanosis, lymphadenopathy or pedal edema. On examination of hands, there is no tremors, the hands are not warm or moist and there is no onycholysis. There is no thickness or redness of skin over shins. There is no vitiligo or no hyperpigmentation. Thyroid examination, patient has a goiter, grade WHO grade 1B, uniform enlargement with smooth surface and no nodularity, no tenderness, though lower border is visible and palpable. There is no bruit and no neck lymph nodes are palpable. This is a picture of the patient's eye. Coming to the examination as seen, the right eye conjunctival swelling was present along with lid swelling and conjunctival redness. With pain on upward and downward gaze, leading to a clinical activity score of 4/7. Left eye showed conjunctival swelling with conjunctival redness and pain on gaze with a clinical active score of 3/7. Exophthalmos, as determined by Hertel's exophthalmometer, was 22 millimeters in both eyes. Visual acuity in the right eye was 6/24 and left eye was 6/9. Lid retraction of 3 mm of the lower lid is visible on the left eye. Right eye lid retraction could not be assessed because the eye itself has deviated upwards at rest. Lid lag is present. Lag of ophthalmos is not present. Pupil is bilaterally symmetrical and reactive. No RAPD. Color vision was normal and confrontation test was also normal. This the diagram at the right shows the restriction of movement. As we can see in the right eye, there was restriction of movement in the downward and lateral directions, and in the left eye, there was restriction of lateral movement. Systemic examination was within normal limits, and diagnosis, Patient is a case of Graves' disease with thyroid-associated ophthalmopathy, clinically active disease with a clinical activity score of 4/7 in the right eye and 3/7 in the left eye, with moderate severe in terms of severity. Currently euthyroid without dermopathy, without acropathy. Coming to the investigations, patient's hemoglobin was 14 gram percent with a total leukocyte count of 6,000. Differential neutrophils were 70%, lymphocytes were 22%, eosinophils 5%, and monocytes 3%. Platelets of 2.7 lakh per cubic millimeter. SGPT and OT were 18 and 23, alkaline phosphatase 60, bilirubin 0.5, and total protein and albumin of 7.5 and 4.3 respectively. Total cholesterol was 205, triglycerides were 234, HDL 64, and LDL of 94. All the viral markers were negative and fundoscopy was normal. Here is a history and the current thyroid function tests of the patient. At the time of diagnosis, that was in 2017, patient had a suppressed TSH of less than 0.01, total T4 of more than 30 milligrams per deciliter, and total T4 of more than 30 milligrams per deciliter, and total T3 of more than 800 nanograms per deciliter. On 6th of July 2021, when the patient first presented to us, his TSH was elevated at 12.4 microinternational units per ml, and FT4 was 0.9 nanogram per deciliter. Total T3 at that time was not available. On 24th of November, his TSH was 2.46, total T4 of 8.7, and total T3 of 1.08. On 24th of December, his TSH was 1.7 and a free T4 of 1.4. CT orbit was done, which showed in the coronal section and both coronal and sagittal section, we can see a superior rectus thickening and medial rectus thickening, and there was also retroorbital fat stranding. Thank you.
Thank you, Ashashri, for presenting the case comprehensively. Would Dr. Mala like to take over?
Yes, thank you, Yashasvi. That was a very nice presentation. And however, I have a few questions. So we did talk about COVID now, and also I would like to know that he has received his full treatment of steroids and he is now euthyroid. What is your plan of action now? And also, in a situation of COVID, what is your take on giving steroids?
Ma'am, a plan of action currently, ma'am, the patient is euthyroid, but he got his last injection of rituximab only 4 days back. So we still we can wait for 2 weeks to see if the patient has a response to treatment or not. And we can also see if there's further any diminution of vision, because he had complained and there was only slight diminution of vision on checking for visual acuity. So we can see if the patient has improvement, then we do not need to go for any active treatment for the orbitopathy. And since patient is euthyroid at 10 milligrams of carbimazole, we have to continue that for now. And ma'am, with regards to steroids, ma'am, definitely a patient who has received a full dose of methylprednisolone and also high dose methylprednisolone, we need to do a COVID RT-PCR before giving the patient IV steroids. And also, ma'am, the patient has to be made aware that since he is or has received steroids and also immunomodulators, he is at increased risk of complications if he develops COVID.
No, my question was hypothetically, if yes, you were not taking steroids,
yes, ma'am,
and in this scenario, okay, would you give a patient IV methylprednisolone or you will withhold?
Ma'am, if the patient has clinically active disease and he had complaints of diminution of vision, so if we don't go for any steroids, then ma'am, I think it can lead to worsening of vision.
So the current guideline is that you should give, and it will not affect outcome of getting COVID, because none of us have antibodies or the infection is very naive. So even giving steroids will not cause him to get maybe exposure may be there, but no increased chance of getting a COVID severity. That is what the guidelines say. Now, you did talk about activity. What is your severity? What guideline or what method did you use to find out the severity of the disease?
Ma'am, I said that the severity is the severity is divided into mild, moderate, severe, and sight-threatening. So, ma'am, I assessed that the patient had moderate to severe thyroid-associated ophthalmopathy because, ma'am, the patient had the soft tissue involvement was there with lid swelling. And
which scoring did you use? Did you use the Hugo scoring?
Hugo scoring, ma'am, because exophthalmos was more than 3 millimeters, like more than the cutoff, and also, ma'am, the lid retraction was also there, and the patient also had diplopia, which was now present, like constant diplopia patient had. So that also puts him in the category of moderate severe thyroid associated ophthalmopathy.
You had told in your history that patient has limitation of some eye movement when you were telling about physical examination. So yes. Based on that, which are the muscles that have been involved on the left side? Right side you have said, and left side also you said.
Yes, ma'am. Left side also, ma'am, the patient had restriction of movement laterally. So, ma'am, the medial rectus was the muscle that was involved. And right side, ma'am, the patient had restriction of movement upwards and laterally. So, sorry, restriction of movement downwards and laterally. So in that case, ma'am, the superior rectus and medial rectus were involved.
What is nerve supply?
Ma'am, like the superior oblique is supplied by the 4th cranial nerve, the lateral rectus is supplied by the 6th, and all the others are supplied by the 3rd.
Yeah. So you told that you're given rituximab. Which is the best option of therapy in a best scenario? Which are the monoclonal antibodies and how do they work?
Ma'am, currently, still the first line remains IV steroids, but after that, ma'am, the one that has been now FDA approved is teprotumumab, which is an IGF-1 receptor antagonist. So, ma'am, that has been approved, and especially in cases of severe proptosis, it has been shown to significantly reduce proptosis. So, ma'am, besides that, tocilizumab is also being proposed as a second line, but the only FDA approved one is teprotumumab, along with rituximab, and the others are ma'am, cyclosporin and tacrolimus.
How does tacrolimus work?
Ma'am, tacrolimus is an anti-interferon gamma. Anti-calcineurin inhibitor. Calcineurin inhibitor, sir. It is a calcineurin inhibitor.
Okay. So temporarily, till you wait for your rituximab to work, do you want to tell him few things, what he should do, what he should not do, how he can protect his eyes in the meantime?
Yes, ma'am. Ma'am, for such the patient has proptosis, so and also going out, patient if has dryness of eyes, we can advise him carboxymethyl cellulose eye drops, artificial tears. While sleeping, if the patient has lag of ophthalmos, though this patient did not significantly have that, but if there is we can ask him to tape the eyes if there is significant exposure of the eyes, so we can ask him to tape the eyes, use dark goggles while going out. Patient is not a smoker, but if he's a smoker, we have to ask him to completely stop smoking. And regular thyroid function tests, ma'am, to ensure that the patient remains euthyroid and not go into hypo or hyperthyroidism. And
is there any contraindication for IV steroids in patients with Graves' disease? Apart from saying I won't give radio ablation, apart from that, is for IV steroids, is there any other contraindication?
Yes, ma'am. Active viral hepatitis is a contraindication. Severe hepatic dysfunction. Patient has severe uncontrolled diabetes or blood pressure dysfunction. Or, ma'am, even severe glaucoma is also a contraindication. And, ma'am, psychiatric illness is also considered to be a contraindication.
So, Dr.
Yeah.
Subankar, any questions from your side?
Yeah. Let's open out as well, and let's have others on board, at least from the 11 that have joined, apart from Yashashri. So that was good, Yashashri. So if we do we have Dr. Manoj Reddy? And for him, I would like to know the history that was provided is that he had first diagnosis of Graves' disease, and probably after a couple of years or 3 years, he developed features of ophthalmopathy. So how these two entities behave in terms of temporal presentation? Do they all behave this way, that first you have the hyperthyroid phase and then you have the ophthalmopathy? We have Dr. Manoj Reddy. Yes. I can't hear you.
Sir,
Maybe
am I audible now, sir?
It's better now. Yeah.
Yes,
Tell
sir.
me.
Ophthalmopathy can precede symptoms of hyperthyroidism, or can concomitantly present with symptoms of hyperthyroidism, or can afterwards present with thyroid ophthalmopathy can present after development of symptoms of Graves' disease also. 30% can present with before presentation of Graves' symptom. 30% can present with concomitant symptoms of thyroid ophthalmopathy. 30% can present with post. And euthyroid ophthalmopathy also can be.
Yes, and hypothyroid ophthalmopathy, can it happen in hypothyroid individuals?
Yes,
that
sir.
can
Hypothyroid.
also, much less common, but
10%.
right. And what could be a possible reason for maybe precipitation of ophthalmopathy in this particular individual? Any particular reason that you can think of?
Non-adherence to antithyroid.
Sorry? Maybe there are connectivity issues. Can we have Dr. Deepak Kulkarni? Yeah, thank you, Manoj. Thank you, Manoj.
Yes.
Dr. Deepa?
Phase of hypothyroidism that occurred in between, where his TSH went to 12. So
yes, I mean, that could be a possible factor. Yeah, and so any idea as to why precipitation of hypothyroidism should cause, whereas we have said that ophthalmopathy itself in hypothyroidism is much less. Mostly it's with hyperthyroid states.
So, but then it leads to the accumulation of glycosaminoglycans in the muscle tissue, which probably absorbs the water and then swells the muscle up. So the swelling.
Possibly. Okay. And she did tell us that he has got some visual impairment. So what could lead to visual impairment? Am I audible?
Yes, sir.
Deepa. Yeah, okay. So what could be the causes of visual impairment in a patient with Graves' ophthalmopathy or orbitopathy?
So the of the movements can cause him.
That's a sort of visual difficulty. I mean, what you're saying is maybe the diplopia part, but apart from that, could there be visual impairment in terms of decrease in visual acuity?
Yes, sir.
Why? How?
Once we mentioned, sir.
Okay, let's have Umesh. Thank you, Deepa. So can we have Umesh, Dr. Umesh Shah?
Yes, sir. Yes, sir. Sir, it could be because of change in visual acuity, sir. Maybe that edema the patient has, sir, conjunctival edema and.
Conjunctival edema, how much does that contribute to the overall refractive index of the visual apparatus? Very little. What else? Okay, that could potentially be a small factor. And besides conjunctiva, does it cover the cornea? Now that's very basic anatomy. So conjunctiva is only outside the cornea, isn't it?
Yes, sir.
So why should it affect your vision? It's only covering your sclera. You don't see through your sclera, do you?
Yes, sir.
So that is not accepted. What else?
Maybe that so much of edema, sir, and that causing
Where? Edema where? You have to think of the visual pathway.
Yes, sir, edema near the optic nerve, sir.
Edema near the optic nerve. Okay. So that would cause pressure on the optic nerve.
Yes, sir.
Right? Okay. That's accepted. And how can, and so what is this entity known as? Some acronym and a full form?
This optic neuropathy, sir. This
Yeah. And those film buffs would remember DON. D-O-N.
Yes, sir.
Right. And so do you know of any, maybe we go on to the next person, maybe Orijit. Orijit, do you know of any radiological sign that can help us to predict presence of DON?
There are several scores. One is major index.
Sorry? I couldn't hear you properly. Are you there, Orijit? Maybe still connectivity issues. Shall we go on to someone else? Orijit, you're muted now. Unmute yourself.
So can
Yes.
you hear me? Hello? Hello?
Yes. Please answer. Yeah.
Sir, can you hear me? Hello?
I can hear you.
Okay,
Not
sir.
very clear. Yeah.
Okay, sir. Sir, in case of DON, there is collapse of the retroorbital fat, which can be seen in the CT scan of the orbit. And there are several two scores by which we can predict the presence of DON is there. Now, one is nasal index, and the second is don't want B by B.
Yeah, something to do with the esophagus as well. Barrett.
Barrett's, yes, sir.
So what is Barrett's esophagus? What is Barrett's esophagus?
Barrett's,
Any idea?
Barrett's,
It's not endocrinology, but it's medicine nonetheless.
It is due to the reflux of the acidity towards the.
Is that okay?
It due to and for reflux there is.
Anyway,
dysphagia of the
let's come to Barrett's index. So what is this Barrett's index roughly? Do you know? So do we do how do you assess it? Is it on an X-ray, ultrasound, CT?
By CT scan, we will do the CT scan of the orbit at the mid-orbital level between the pole of retroorbit and the apex of the orbit, and we will measure the diameter of the various muscles, superior rectus, inferior rectus, medial rectus, and lateral rectus, and by summation of the diameter of the.
Isn't there a vertical index and a horizontal index?
Yes, sir.
Right.
What can I remember? That if the vertical index is more than 55, then possibly there is a chance of this type of neuropathy.
Okay. Now, other causes for visual impairment in patients with Graves' orbitopathy, Dr. Pankaj Singhania.
Sir, good afternoon, sir. So other than dysthyroid optic neuropathy, another important cause can be exposure keratitis because of corneal breakdown, which can happen in patients who have unprotected eyes with significant proptosis. Other than these, stretching of the optic nerve because of subluxation of the globe, or increased orbital fibrosis in the retroorbital space post radiotherapy. Radiation can also lead to worsening. Sometimes transient worsening can also happen in these patients.
Right, thank you. Dr. Praveen Kumar, so for diagnosing Graves' orbitopathy, what tests do you need to do? Would you do? Dr. Praveen?
Yes, sir. Good afternoon, sir. So
Good
we had to check for presence of proptosis by Hartard's ophthalmometer, and we can assess if it is more than 18 millimeters that suggests there is proptosis. Then we have to know whether it is bilateral or unilateral proptosis. More than 21 millimeters signifies moderate proptosis, and this is the basic thing. And followed by, like, we have to do the clinical activity scoring system to understand the activity of the clinical severity of the Graves orbitopathy, sir.
So, have you ever used an exophthalmometer?
Sir?
Have you used an exophthalmometer yourself?
No, sir. Actually, we are measuring it on OPD method from the lateral border of the orbit to the to the surface of the cornea. That measurements we are calculating.
Okay, fair enough. And then any other investigations? Would you like to have any other investigations?
Radiologically, we can do a CT or orbit, which can provide the information regarding the involvement of the extraocular muscles, sir.
Mm-hmm.
And also, it can also give us information regarding the retroorbital fat deposition.
Mm-hmm. So, how does fat look on a CT scan? And how does it look on ultrasound scan? Fat? Is it white or black on CT?
So it will be.
You're not
black,
sure?
Sir.
It will be black. On ultrasound? On ultrasound? On ultrasound?
Sir, there will be reflection because of the water content. So
fat is. I thought fat does not like water.
CT scan, sir.
Sorry, on ultrasound, how does fat look like? Is it white or black?
Ultrasound.
You're not sure. Okay, so please look that up. Look that up. I mean, it's not just in the orbit. It's about the abdomen. It could be about your adrenal glands when we're looking at maybe myelolipoma or whatever.
It will be it will be increase in the intensity, sir. It will be refract, right?
Yeah, right, exactly. So, Dr. Abhishek Prakash, what about MRI scan? You've got CT scan and you've also got MRI scan. You also, of course, got ultrasound scan at your disposal. So which one would you advise if you want to do an imaging?
Good evening, sir.
Good evening.
So you're asking me among the three, which one I should advise first?
Yes, if you have access to all of them, and cost is not an important consideration. And I mean, fortunately, at this point of time in our state and the government institutes, all investigations are free. So for me, it's as easy to advise an MRI as is to advise an CT or ultrasound. So which one should I go for?
So as per me, I would like to go with MRI because the soft tissue resolution is much better with MRI, and the thickness of the muscles, the status of the orbital apex, the soft tissues and the fat, they will be more delineated with MRI rather than the two modalities, sir.
So your CT scan also will give you a thickness of the muscle, maybe 5.2 millimeters, 3.4, whatever. MRI would also give you the same. So what additional information will your MRI give you that may have therapeutic implications?
Therapeutic.
Maybe Dr. Mala is a much better examiner. Yeah, sure, she was answering all her questions. So maybe it's back to Mala.
I'm muted. Dr. Varsha, are you there?
Yes, ma'am.
So, Dr. Varsha, we have been talking about lot of investigation. Can you tell me the role of TSH receptor antibody?
Yes, ma'am. We can do TSH receptor antibodies to determine whether the underlying thyroid autoimmunity is present or not. This is particularly helpful in cases when like patient is euthyroid or hypothyroid.
What are the other uses of this receptor antibody? Do you know of any?
Ma'am, can help to know the relationship between disease activity and the severity, and most importantly, the prognostic value.
So do you know of any current medication that is aimed at this modality, which is in progress, is in phase 2 studies, where they're looking for therapy? Do you know of any recent pharmacotherapy that is, tell me the recent not what you already have, what is in the pipeline? What are the drugs in the pipeline for treatment? We know that the treatment that we are having so far for TAO is far from ideal. So we do know that the interleukins are high and cytokines are high. So we are trying to give anti-inflammatories, right? So but that's not ideal. We are just sort of trying to control the inflammation. Is there something else that is coming up which is aimed at actual treatment? Do you know of any new modalities?
Maybe something with related to TRAB antibodies, but I'm not aware of that.
So we can ask Lakshman Kumar. Dr. Lakshman, do you want to answer that?
Good afternoon, ma'am. Regarding anti-TRAPS antibodies, I am not sure, ma'am. But anti-TRAPS like TRAPS antibodies has a role in pregnancy also, ma'am. You asked previously. So the role of TRAPS is it has a role during monitoring of hyperthyroidism in pregnancy, ma'am. Higher titers, we need to have a clear follow-up regarding the fetal status, and we need to monitor regularly.
So is there, let's say, if a person is there with Graves' disease and is not pregnant, and we are doing a radioactive scan, whether it's a technetium or an iodine scan, is there any role for TSH receptor after knowing it's Graves? Is there any other role for TSH receptor antibody?
Yes, ma'am. Yes, ma'am. Presence of TRAPS antibodies will indicate there might be progression to thyroid associated ophthalmopathy, because TSH receptor antibodies also present in the orbital tissue. That is the main pathophysiology for the progression of TAO. And sometimes we will have a dilemma whether it is thyroid associated ophthalmopathy or not. In that case also, we can use TRAPS to delineate, because sometimes patient may present with the TAO itself rather than presenting in hyperthyroidism. So in that case also, it has a role.
Okay. So shall we go to Dr. Yashasvi? Are you there, Dr. Yashasvi?
Yes, ma'am. I'm here.
Everybody has talked of many things. Can you tell me what is the expansion of VISA, which is a severity scoring?
Yes, ma'am. It is vision, inflammation, I think strabismus and appearance.
Yeah.
Yes.
So in this regard, when you have a very severe eye disease, patient comes and you feel there will be subluxation, what is the best therapy you would give?
For severe eye disease, ma'am.
Yes. Very severe sight-threatening eye disease.
Ma'am, for very severe sight-threatening eye disease, ma'am, there are, ma'am, two options. There has been suggested that we first go for high-dose pulse IV methylprednisolone, 500 or 1000 milligrams for 3 consecutive days. And also, ma'am, orbital decompression surgery also. So if that is not successful, then we have to go for decompression surgery.
No, radiotherapy does not have a role, yes, but decompression,
yes,
that is what we'll go for first.
Yes,
and because now that you've put yourself, you can tell me, when will you do radiotherapy?
Ma'am, radiotherapy, said it by mistake, ma'am. Radiotherapy is generally done for moderate severe the tau only. It is a second line treatment, ma'am, and it generally helps with with diplopia. So generally given in along with oral or IV steroids, and it's a second line therapy for moderate to severe thyroid associated ophthalmopathy, not for sight threatening.
So thank you, Yashasvi. And we have Dr. Supreet. Dr. Supreet, are you there?
Yes, ma'am.
So in a person who has, tell me what is normal, when you call proptosis in Asian Indians, is there any data that has come out to say this is more than this is high? And is it different from Caucasians?
Usually in Indian population, for females, it is around 6 to 14. And in male, it is around 14 to 18 mm. And if it is above 3 mm, above the upper normal limit, we call it as a proptosis.
Yeah, so it is for the race, for that race, what it is, and above 3 millimeters for that race. And we Asians apparently have a very small orbital volume. This study was done in China where they found, and then some studies have come also from India where they have found that the orbital volume is around 17 or 18. And that is why that cut off. So, yeah. So let's say in a patient who has come with you first time, this is again arbitrary, not this particular patient, who comes with hyperthyroid, you have confirmed it, and he has also eye disease. Which drug you will give immediately, and what is your aim for treatment? Is there anything to say that you should do it like this and that will benefit eye disease?
Usually suppress TSH less than 2.5 or less than the half of the target range, and T4 and T3 levels have to be normalized with the upper normal limit. And
this is not in pregnancy. I'm just talking about everybody. So what is the relationship of eye disease to thyroid status?
On thyroid, most of 90% of the hyperthyroid, usually thyroid eye disease is seen in 90% of hyperthyroid, and it can also be seen in 5 to 10% of euthyroid and also hypothyroid.
90% of hyperthyroid, and your reference?
90% of the thyroid eye disease patients will have hyperthyroid, and rest of 5 to 10%.
Okay, you're not saying hyperthyroid, 90% have eye disease. You're saying in eye disease, 90% will be hyperthyroid. And then the other will be, 10% will be?
Hypothyroid and euthyroid patients. Even in these patients,
gradually euthyroid will maybe become into hyperthyroid later. That's what you're saying. The phase will be first euthyroid and then become hyperthyroid. Is that what you're saying? Or you're saying euthyroid patients, just like hypothyroid? Hypothyroid, the question was asked. Do you know any particular percentage that has been documented?
5%. 5% of hypothyroid patients.
What hypothyroid? Any particular hypothyroid? So many causes are there, isn't it? What causes?
Autoimmune Hashimoto's.
Hashimoto's thyroiditis, right. So in this monoclonal antibody, rituximab works at what level? We can ask the next person again. Thank you, Dr. Supreet. I think Manoj's internet was not so good.
It's audible to me, ma'am.
Yeah, sure. Go ahead.
Rituximab will act at anti-CD20 level, so it will deplete the beta lymphocytes.
Good. Very nice. Yes. So we'll go back to Dr. Shubhankar while I think of something.
Okay. Yeah, good. So we're maybe back to more basic things about smoking. Yashoshi said that this gentleman does not smoke. She was happy about that. So what is the link between smoking and Graves' orbitopathy? Manoj?
Smoking will increase the risk of Graves orbitopathy. And
Why? Why? Is it any tobacco or is it smoking?
maybe smoking, sir. And because of the additives, apart from the tobacco, there are many carcinogens, mutagens.
No, we are talking of Graves ophthalmopathy. So,
Maybe.
how does smoking link to or lead to or worsen, aggravate Graves ophthalmopathy? What's the likely mechanism? It's a well observed fact.
Exact mechanism I don't know. Sorry.
Anyone else would like to try? Apart from Manoj?
Maybe that
Smoking
byproduct.
increasing the
Sorry,
cytokine
Umesh?
concentration.
Sorry, Umesh, once
Yes.
again.
Sir, the smoke contains certain byproducts that is linked to the that worsening of this ophthalmopathy, orbitopathy, sir.
Right. That's a little bit vague. Anyone else?
Sir, the cytokines which are generated in these patients, like TNF alpha, IL-1, these have stimulatory effects on the orbital fibroblasts, thus leading to worsening of the orbitopathy in these patients.
Right. Could carboxyhemoglobin or hypoxia, could all those be factors as well?
Yes, sir, that could also be a factor. The hypoxia present in these patients could also be as stimulating.
Okay. Right. So, what are the current means 2021 UGOGO recommendations regarding management of Graves ophthalmopathy? Has there been any change in recent times? Yeah, so who was the last?
First line, sir, change has been in the first line treatment of Graves orbitopathy. They have introduced actually steroids plus this mycophenolate of it as a first line.
Mycophenolate. Right, and do we have experience in using that? And are you using in your institute, Sajad?
Sir, recently we had a patient. We had actually given him the first line treatment of IV steroid as a standard protocol for around 4 weeks, but the clinical activity score did not improve. So we tried to introduce mycophenolate mofetil, though we gave a higher dose of 500 milligrams BD in addition to the usual dose of steroids that she was already on. We are yet to follow the patients on follow-up, sir. But
so do you think it helped matters? Because I have practically no experience myself, so I'm trying to learn.
But we are just following the patient. It is almost
okay.
Just one question. What is the dose of MMF?
Ma'am, usual dose is 750 milligrams.
Why you give 750 milligrams? You actually give 1000 milligrams to get 0.72 of mycophenolate sodium. So that is sodium 1000. Yeah. And what is the role of selenium? Anybody wants to answer?
Selenium has a role in mild cases of Graves ophthalmopathy, ma'am.
So for that, we need to know whether our country's selenium is deficient or is it enough? What do you think?
We have enough of selenium.
So if we have enough of selenium, maybe for us it's not that useful, isn't it?
Yeah.
It's only for selenium deficient areas they are recommending selenium.
Right. So before embarking, so the standard treatment is IV methylprednisolone. It has so far been. Now maybe we may or may not add mycophenolate to that. So before you start someone on on steroids, IV steroids, pulse doses, what evaluation do you need for the patient? Do you normally undertake?
Blood sugars and LFT, especially.
Sorry? One was sugar.
Sugars, LFT, and blood pressure, and
Right,
cardiovascular states, in fact.
We have to do chest X-ray also.
Chest X-ray. Why do you do chest X-ray?
To see any focal or inactive lesion of tuberculosis is there, because by giving the steroid, the tuberculosis may pick up.
Okay, that may flare. Okay, right. And blood glucose, let's say the blood glucose comes out as 200, or fasting glucose of 200. So what would you do? Or is it? Would you not treat, or would you treat with
Yes,
steroid?
sir. Yes, sir. If the blood sugar level is high, we will definitely give steroid, as there is indication to give steroid. But we have to control the blood sugar by giving insulin.
Okay, so let's say the glucose was 95 fasting to start with. So would you not check glucose level even after starting steroid, or just checking before is enough?
No, sir. Obviously, we have to check the blood sugar level, even if the fasting blood sugar is within normal range, because by giving the steroid, it has been seen in the post lunch, particularly in the afternoon period, the blood sugar level may rise. So we have to check the blood sugar periodically.
Right. So it may be normal before starting steroids. After starting, it may increase also. So-called steroid-induced diabetes, and that also needs to be managed. Right. And why liver function test?
Because steroid can, the high dose of steroid can itself induce hepatic failure, particularly due to the methyl group of the steroid. And it also can reactivate rather, the underlying hepatitis.
Yeah, to exclude existing hepatitis, which may not have been picked up clinically, and also in the long term, large doses of steroids, prolonged course of steroids, of course, could give rise to further liver dysfunction. Right. In terms of treatment, I think Yashasvi herself talked about teprotumumab. So who can, maybe, shall we have Dr. Deepa enlighten us a little more about this difficult to pronounce, for me at least, entity, the monoclonal antibody?
Sir, I know that it is an IGF receptor antagonist. I don't know much about it. Sorry.
So why use it? Are we treating acromegaly here?
No, sir.
Then?
Those receptors are supposed to be present over the extraorbital.
Sorry?
The orbital muscles, or extraorbital ocular muscles, sorry.
So again, back to pathogenesis, is the muscle itself as fault, or is it some other cellular element which actually drives the process?
Sir, along with IGF-1, for the action of TSH receptor antibody, IGF-1 is required for the coupling action, which activates the fibroblasts. So by blocking these IGF-1 receptors, we will block this fibroblast from activating and multiplying into muscle fibers as well as the fat tissues. So thereby it helps in one thing, like it retards the progression of the proptosis, as well as this drug has shown to be reduce the proptosis size significantly in most of the patients that has been used.
Right. So Praveen, so how do you use this drug? Dose, I mean, how frequently? Is it oral or rectal? How do you administer the drug? Any idea? Of course, it's not available to us.
Sir, I'm a little doubt, but I think it's given once in 6 months. Dosage is
not in 6 months. No, not in 6 months. More frequent, but not daily.
So actually,
yeah.
So
It's a Pankaj. Yeah.
Yes, so it's an IV drug, which is generally given in an initial dose of 10 milligram per kg body weight, and subsequent doses of 20 milligram per kg body weight to be repeated at intervals which can vary from 3 to 21 weeks depending on various protocols.
Okay, I thought 3 weeks. Okay, fair enough. And what would be the likely side effects? Side effects? Yes.
The side effects could be some infusion reactions, anaphylaxis.
Yeah. Okay.
And
beyond that,
hyperglycemia.
Hypo or hyper?
Hyper.
Yes, hyperglycemia could be an issue even with this drug. And do you know of based on which study US FDA approved this drug?
In NEJM, I do not remember the name of the study. I think there was one study in NEJM, I believe, which
yeah.
Yes.
Okay. So can we? So we are being shown now group 2 participants as well. So maybe we will gradually wind up. So overall, this we do not have access to. So what's the natural cause of Graves' ophthalmopathy? Can we have someone telling us? Maybe Dr. Abhishek. What is the natural cause? Abhishek? Do they all need treatment? Invariably need treatment? Everyone gets corneal ulcer or optic neuropathy?
I think anyone who's there can answer. The Abhishek doesn't seem to be there.
Okay. Varsha?
Associated ophthalmopathy, the natural course is explained by Randall's curve, ma'am. So basically, over an initial period of 6 to 8 months, there will be gradual progression and there will be a stabilization phase of around 1 to 1.5 years. And beyond 2 years, it will be static, like no change in the further course of the disease.
Regression? I mean, can it not regress?
At the end of one stable phase, it can regress, sir. At the end of phase, sir.
Yeah. Okay. So finally, let's try and address this particular patient. So maybe Yashasvi, maybe you know more about this gentleman. So you tell us, and that's something that Dr. Mala Dharmalingam asked you initially. So what are your plans for this patient? Are we happy with the results, or you have administered rituximab as your second line agent?
Yes, sir. So we have given rituximab, sir. The second dose of it was given around 4 days back. The patient was discharged yesterday after that, sir. So, sir, we are awaiting response from that, sir. And, sir, if not, sir, then probably, sir, because the patient, sir, after the steroid treatment, he had some improvement, and the patient was saying...
So what is the improvement that you're looking for in this patient?
So improvements are both,
because from the photo that you showed,
yes,
it doesn't have a lot of proptosis. At least, I mean, your measurement may show 22 millimeters, which is more than maybe the standard, but didn't have a lot of proptosis, I thought.
Yes, sir.
Mala?
Yes, I agree. I think more of strabismus was there.
Yes, ma'am. Strabismus, ma'am, and because of that diplopia he had, diplopia and visual acuity when he had first come, sir, it was 6/6, and now it was 6/9 in one eye and 6/24 in the other eye.
So could this be a steroid-induced cataract that he's developing? Though there's more common with topical steroids.
Yes, sir, but he went for an ophthalmological examination, sir. Anterior chamber was fine, and the fundus also, they said that the optic disc is also fine, and there were no significant changes in that also, sir. But, sir...
So before embarking on further courses of immunomodulatory treatment, wouldn't you like to see if there is significant inflammatory component in his disease? In other words, you could have strabismus as an end result of Graves' ophthalmopathy with fibrosis having set in. In that situation, anti-inflammatory treatment may not work well, whatever
yes.
you give.
Yes, sir. Right.
So in this context, I come back to my issue whether MRI could be helpful.
Yes, sir. So that was the plan, sir. Like after we've called him for follow-up after 2 weeks, sir, and we've said that we'll go for an MRI, like depending on his response and all of it.
Right? Good.
Yes,
So maybe final word from Dr. Mala before we hand over to the next group for the second case.
So I thank all the participants, especially the initial presenter, and all of you have done a great job. This is a very common problem that we see in our endocrine practice. And when the patient is sitting in front of you, you have to evaluate each one of them. And depending on that requirement of that particular patient, whether he's mild orbitopathy or moderate or severe, you have to implement the correct treatment and also the modality to treat his hyperthyroidism also. So though we have not discussed here, maybe a mild orbitopathy or even a moderate orbitopathy, and if he's not getting controlled with oral anti-diabetic anti-thyroid agents, a role for radioablation is also there under the cover of steroids if the patient is having moderate orbitopathy. Mild, I still believe you can still give radioablation, nothing much will happen. So with that, I thank everyone. And if there's anything else that Dr. Subankar wants to add, I think it was a really nice session and we enjoyed it.
Yeah, thank you. And next sessions, Vagish or anyone, do you have any comment, a question, anything?
Just I think there was two things were brought in the discussion. Why Asians have got a lesser problem and Caucasians have got a more problem. Anyone can highlight on that?
Just now, Dr. Mala told us that we have smaller orbits. So if you have a smaller orbit, we should have a bigger problem.
Yes. So why the things? So I think that was evolutionally it has been studied. What happened is Caucasians were explorers. They went out to the ocean with the wide eyes. We were hunters and gatherers. We always aimed with the closed eyes. That's why what happened, our orbit pushed inside. Their orbit came out. That's why that is one of the evolutionary explanation they do give why Asians do have a lesser thing and Caucasians have a thing.
But Vagish especially, and maybe we can claim also that we are far-sighted, maybe more far-sighted than the Caucasians. We would like to claim. Anyway, thank you. And Rajesh, did you have a point to make?
No, sir.
Thank you very much. Thanks for joining. So we go to the next case. Shomik, please.
Yes. Sincere thanks to Professor Shubhankar Chaudhary and Professor Mala Dharmalingam for enriching us with that nice discussion, wonderful discussion on thyroid eye disease. And I hope that with this discussion, our students will face their examinations and face patients later in their practice with even greater confidence. We now move over to case number 2, and to present this case, we have Dr. Shubhashish Neogi, who is presently a postdoctoral trainee at the Department of Endocrinology at IPGMER and SSKM Hospital, Kolkata. The group 2 participants, we have their names in the chat box, and I request examiners to use the chat box to go through their names so that the questions can be asked sequentially to the participants who are there in group 2. As regards the examiners for case 2, they need no introduction. They are known across the country. They are respected. They are reputed examiners. We have Professor Rajesh Khargawat from the Department of Endocrinology at All India Institute of Medical Sciences, New Delhi. And we have Professor Vagish Iyer from St. John's Medical College, Bengaluru. Over to our examiners and over to Dr. Shubhashish Neogi to take us through case number 2 of this year's EEP.
Good evening, sir. Sir, am I audible?
Yeah.
Yes, you are audible. Yes, clearly audible.
Sir, I'm sharing the screen, so just a second.
Please.
Sir, is my screen visible, sir?
Yes, it's visible.
Yes.
You can go ahead. Just make it in presentation mode.
Yes.
Yeah, you can go ahead.
Okay. Good evening, respected faculty members and all the attendees. At the outset, I want to thank the organizers of EEP for giving me this opportunity to present this case. 3-year, 5-month-old child presented with atypical genitalia, which was noticed since birth. The child was born out of non-consanguineous marriage, cesarean section, term with birth weight of 2.5 kg. Mother noticed atypical genitalia since birth in the form of bifid scrotum, small phallus, and bilateral labioscrotal mass. They attended endocrinology OPD at the age of 1 month, and evaluation started, however, was not completed, and the patient lost to follow-up. There was no history suggestive of any adrenal crisis in the form of repeated episodes of vomiting or poor feeding or failure to thrive, any hyperpigmentation of the skin or genitalia, any other perinatal complication in the form of repeated episodes of seizures or hypoglycemia or neonatal jaundice, any history of frothy urination or pain abdomen, any history of drug intake during pregnancy or any history of maternal virilization. There was no similar presentation in family members or any miscarriage or neonatal death in the family. There was no family history of any infertility, delayed puberty, or primary amenorrhea. The developmental milestones were normal for age. The child did not have any other sibling, and the naming of the child has not been done yet, and the sex of rearing is also not decided. There is no history of any corrective surgery or treatment in any form of cream, lotion, or any injections that have been given. Mother noticed increase in phallic length and the deformity has been non-progressive. To summarize, 3-year, 5-month-old child born out of non-consanguineous marriage presented with atypical genitalia without any history of adrenal crisis, hyperpigmentation, maternal drug use during pregnancy, or any family history of atypical genitalia or primary amenorrhea.
Dr. Rajesh, can we break here and ask some questions rather than everything asking in the end?
I think Dr. Shubhankar said initially that we'll continue to have presentation, but I would request Subhashish to just stop last 2 slides, which would be revealing everything and would turn discussion in other direction. So before that, my opinion is we can go ahead with all examination, then we can come back slide by slide to ask more questions.
Sorry. I take back my word. That was a general sort of discussion, but yeah, of course, individual cases one can of course interrupt and ask. Absolutely, please.
Both ways we are happy.
Yeah.
You have to ask question now or after that, it's same.
Yeah.
Okay. Right.
So whatever you feel, you can go ahead.
Fine. So what is the history about the consanguinity and the your atypical genitalia you will get?
How they are related, sir?
Yeah.
Sir, consanguinity is autosomal recessive disorders, sir, are associated with consanguinity. So in this case, sir, if you are thinking of a 46XY DSD, so the possibility is 5 alpha reductase is autosomal recessive, 17 beta HSD3 is also autosomal recessive.
So commonly, your autosomal recessive disorders will be what type of a diseases you will get?
So can you come again, please, sir?
Autosomal recessive disorders, or what are the type of a group of a disorders we'll think of?
So CH group, sir.
Mainly steroidogenous disorders will be an autosomal recessive.
Yes, sir.
Fine. So when you think of a X-linked disorders, what you will be thinking of?
Sir, X-linked disorder, if you are thinking, then we have to think of, sir, androgen insensitivity syndrome, sir.
Yeah, it's an partial or a complete androgen disorder, more of an X-linked disorder. So So can I ask the next person in the list, Rashmi? There are some history of a maternal ingestion of a drugs. What are the important drugs you want to inquire? Dr. Rashmi?
if Rashmi is not here, next one,
Yeah,
Mahesh can take.
Yeah,
Mahesh
anybody
can take that.
Yeah, anybody can take.
Sir, I'm just interrupting, sir. There's a second list there, group 2 joined. They are the ones who have joined out of that big list. So if you can just scroll down, there are about 8 people who have joined actually.
Oh, okay.
So you can begin from that list, sir.
Yeah, so Lavanya comes first.
Yeah. Mr. Das. Devaditya Das.
Yes, sir.
Yeah, Devaditya Das, what is the history of a maternal drug injection you want to inquire? And which all situation they would have given it?
So one of the drugs would be danazol, which is used in endometriosis, treatment of endometriosis, that can actually have a androgenic effect if continued throughout the pregnancy.
Yeah, but now availability and it's almost stopped. It is nobody is prescribing it.
And why somebody will use this drug in suspected pregnancy?
Yeah, you are still by stall danazol or all of the past.
Sir, then
what are the current things which can have?
Progestins that have androgenic properties.
Like?
Sir, the earlier generation progestins like levonorgestrel, etc. These things can have androgenic effects on the fetus.
They are given for which situation during a pregnancy?
Sir, luteal phase defect, they can be given also to assist the pregnancy in the first few weeks of pregnancy. The progestins can be given.
Yeah, many times this IVF pregnancies, threatened abortion, they do receive some amount of a progestin support. Fine. So what are the defects you see with these progestins in the newborn in the form of a atypical genitalia?
Sir, if the progestins have androgenic activity, like the earlier generation progestins, then can be virilization in the mother as well as in the fetus, virilization of the genitalia, which is usually static after birth. It does not progress after birth.
Okay, what are the studies have been shown that use of progestins and what is the outcome of the genitalias, or atypical genitalias? Anything link has been found?
Sir, I'm not aware of the studies.
Yeah, anybody is known also fine. Out of 8, whoever is known can come out. Yeah. So the hypospadiasis has been linked with the use of a thing with progestins. So this just a association study, and by and large nowadays we are using is a less androgenic progestin for the safety of the baby. And fine. Any other thing which has been found? Maternal use of the, not a drug, it's any habit of the mother has been resulted in some amount of atypical genitalia. They are again association epidemiological studies.
So smoking and alcohol intake.
Yeah, that's the very thing. History of a smoking and alcohol intake has been shown in some of the European studies. Fine. Yeah. So Dr. Rajesh?
Yeah, can we come to next one? Lavanya is...
no, it's not there. It's the next one it is. I think there are only 8 out of 6.
Subhashish
Yes,
has
sir.
joined?
Yeah, he's presenting.
Sir, I'm doing.
Okay, you are presenting. Then Chetan Dev.
Yeah, Chetan.
Yes, sir.
Are you here?
Yes, sir. I'm there, sir.
Okay, so what's diagnosis? We do not have any more detail. Whatever detail you have seen. So what are your differentials and what would be your first differential?
So from the history, it is clear that the child is having atypical genitalia and is having a biped scrotus, a small phallus, and a labioscrotal mass. So it's a disorder of sex development. The first, either it can be a 46XY or it can be a 46XX.
So do you expect this case to be 46XX right now because of bilateral labioscrotal mass, which is on both sides, and to believe that ovary would descend to that level would be again would be difficult. Yes, theoretically possible.
So because the labioscrotal mass is palpable, so first differential would be a 46XY DSD. However, in some cases of 46XX also mass could be palpable, like in cases of mixed gonadal dysgenesis, some mass could be palpable, sir.
Have you seen that case in your training?
No, sir.
I have also not seen. So if we have both of us, if we have not seen, and I'm not sure Vagish has seen or not.
No, definitely not.
Not seen any ovarian tissue coming down. Yes, rare cases may be there, and these cases are not suspected, but they are diagnosed by diagnostic methods.
Yes.
So most of the time, it's very difficult to reach these cases by clinical diagnosis. So straight away, 3.5-year-old month child with DSD, with these findings and no history of adrenal crisis. Diagnosis now.
Yeah.
So we believe that if you have bilateral labioscrotal mass, which is on both sides, so most likely to be 46XY DSD. Whatever karyotype comes, that's a different issue.
True.
Sir, it could be an androgen synthetic defect or androgen resistance, sir.
So which one would you like to prefer? Synthetic or action?
Synthetic, sir.
Why you say so? But even if you have said action, we would have asked same question.
Yeah.
So why you say synthetic defect means you mean which condition? Are you here?
Yes, sir.
Yeah. So by synthetic defect, which condition you mean? Okay. So most likely, most common case which we are seeing in our practice, and everybody is also seeing that, as this data comes from publications, it's a partial androgen insensitivity.
Yeah.
Versus action defect is partial androgen insensitivity is action defect, 5-alpha reductase deficiency is synthetic defect.
Yes,
Yeah.
sir.
So these are the two common conditions. So which one to prefer where? Any clinical clue to this?
Sir,
Presence of gynecomastia will go in favor of.
No, but you cannot expect gynecomastia in 3.5-year-old child.
But otherwise, if gynecomastia is there, will favor partial androgen.
No, in 3.5-year-old.
Yeah, not expected at this age.
Sir.
Yes, go ahead.
Sir, I'm Subhash. Sir, actually, by seeing the history of the appearance of the genitalia, we can have an idea. Is that the testes have descended into the labioscrotal fold. However, the external genitalia, like there is no scrotal fusion as far as the history, and the phallus is small. This, sir, maybe, sir, this supports more towards 5-alpha reductase deficiency.
I think, can I come in, Dr. Rajesh?
Yeah, sure.
Yeah, fine. I think to some extent I agree with Subhashis, because what they feel is gonads to descend to the scrotum, you require an intact androgen receptor action. So the bizarre majority wise, there's no absolute thing. So possibility of a receptor being intact with action may be deficient, quite possible. That's one such thing. And one more thing about this, there is one very good, I think, older rule. We used to call it as a Federman's rule or a Federman's rule. If the gonad has descended below the inguinal ligament, it has to be a testis or a ootestis, or has to have some Y liner. So ovary as such pure can't descend on its own to the scrotum. This was one of the clinical rule which was used earlier.
Yeah, that's correct. And to have a labioscrotal mass means labioscrotal folds, they are present. So they have to pass both internal and external inguinal ring.
Yes.
Opening they have to cross. And to cross that, which is again a very complex procedure, to have this complete process is seems unlikely to have ovarian tissue. Agree with that. So my opinion is whatever Vagisha said is looks fine. But for exam purpose, I would suggest difficult to choose between these two conditions at 3.5 months of age. Suppose it's at 23 years, we could have said many things which have favored partial or 5-alpha reductase deficiency. But at this stage, it's very difficult to choose. Only thing you can have is in your area, if you have more publications showing that 5-alpha reductase is more common than partial, then you can say 5-alpha reductase, otherwise partial. Hardly much because this is just summary. We haven't examined the yet. So, Dr. Vagish, can we go ahead with some more detail?
Yes, please. Yes, definitely.
Subhash, go ahead with Subhashish.
Yes, just a second. So the slides are not. Oh, sorry.
Yeah, we are seeing. Yes.
Yes. So the child was alert, playful. The height was 91 centimeter, which was the 3rd to 5th percentile. The weight was 14.1 kg, which was around 50th percentile. The blood pressure was 100 by 60 millimeter of mercury, and that is 58 to 90th percentile for both the systolic blood pressure and the diastolic blood pressure for the length of the child. And there was no evidence of any hyperpigmentation, no evidence of any cleft palate, cleft lip, no craniosynostosis, or no skeleton deformity was present.
Subhashish.
Yes, sir.
Yeah. So whenever you tell height, weight, anything like you are using centiles, so it's always better to tell examiner that which data you are speaking about. Most likely this must be Indian Academy of Pediatric charts.
Yes,
so just say the 3rd or 5th centile or IEP chart. So that in that way you will avoid the next 1 or 2 questions. Otherwise, then they will ask which chart, when these charts were produced. So from where data was collected. So just say that these are these charts, and similarly for blood pressure. So it's always better to tell that these are for Indian children, or we are taking these centiles from the Caucasian population.
Okay, sir. Thank you, sir.
Yeah, so it's a minor thing, but examiner would be happy if you tell these things. Okay, go ahead.
Coming to the genital examination, this is the clinical photographs are on the next slide. The scrotum, there was no scrotal fusion. Pigmentation was present. Rugosity was present. Gonads were palpable in both labioscrotal region. There was no irregularity in the gonads on palpation. The volume were 1 ml both. The phallic length was 2.7 centimeter, which is less than 3rd percentile according to the Eastern Indian data what we have. And the glans was developed. There was no chordy. Single opening was there. Perineal hypospadias. The anogenital ratio was 0.6, and the external masculinization score was 3 by 12. These were the clinical images of the gonad, external genitalia.
Okay.
So, Dr. Vagish?
Yeah, I think we'll start discussion here. That should be good.
Yeah.
Yes.
So, who is next?
Yeah. Chetan Dev.
Chetan Dev, are you there?
I just now answered, sir.
Oh, just now. Okay, fine. I think just time.
So, diagnosis. Now, once we have completed history and examination.
What do you think, and what are the things to support your diagnosis?
So, the child is having...
Parth Jethwani next, I think. No, I think this...
Yeah, good afternoon, sir. So I believe the differential diagnosis still stands out what we had after the history. So it's a 46XY DSD. And when we go into 46XY DSDs, we'll be differentiating primarily between androgen biosynthetic defects and androgen insensitivity syndromes. So out of these, so we have already discussed 2, that is 5-alpha reductase type 2 and partial androgen insensitivity syndrome. However, so 17 beta HSD3 is a rare possibility, but it should also be considered in this.
Yeah, so what's your impression about this child regarding the action of androgen in the early weeks of pregnancy?
So in the early weeks of pregnancy, androgens primarily would lead to descent of the testes.
In this case, do you believe that there is a defect in androgen action since early, or it has developed late, or it was present throughout the pregnancy?
So I believe there was a defect in the early half of the pregnancy, sir. not entirely sure, sir, but I do believe that there was a defect, because if there was a defect in the later half of the pregnancy, then it would have presented just with isolated hypogonadotropic hypogonadism.
Not that late. Not that late. We have a critical window below 8, 8 to 12, and after 12. So if you have androgen deficiency after 12, there is hardly any ambiguity.
Right, sir.
And before 8, again, if there is no effective testosterone, again, there is hardly any ambiguity. They will be phenotypically female. So most of these is between 8 to 12. So what's your comment on glands? So if you are describing glands, anything else would you like to tell?
So Cordy would be something that we can comment on.
He said, Subhashi said Cordy is absent, if I remember correctly.
No Cordy, he said.
Yeah. So Cordy is not there. So what do you mean by Cordy?
So that's why. So that's bending of the dorsal curvature of the penis, sir.
Why it happened?
So that's because of there is a abnormal distribution of the tissue on both on the dorsal and ventral surfaces, which then subsequently leads to increased curvature on the ventral side.
And the anatomical place where this Cordy occurs belongs to which area? Which structure?
The corpus spongiosum, sir.
So why corpus spongiosum is not developed?
So I'm not sure.
But I believe is that Cordy is the place of developing of future urethra. So future urethra doesn't develop because of defective androgen action or receptor whatever. So that the anatomical place of future urethra is replaced by the fibrous tissue. As testis grows, but fibrous tissue doesn't grow. So as testis, as the penis grows, fibrous tissue will not grow, so it will bend downwards, and that's what we call as Cordy. So it's a place of future urethra, which doesn't traverses from the pinoscrotal region to the tip of glans.
Right, sir.
So do we make any comment on opening on the tip of glans or in the glans? So whenever we describe, it's always better to say that glans is well developed, and glans is well developed means there is a good effective androgen actions, whether it's a 46XY or 46XX. So development of glans required good amount of testosterone. So that simply shows that there was a good amount of testosterone. Even if there is no opening, like in this case, there is a pinoscrotal hypospadiasis, we believe so opening is there. So it's always better to describe that glans is well formed and there is no opening on the tip or anywhere in the glans.
Right.
Okay, go ahead.
So just
So
one more.
Yes,
Yeah. When you see a single opening, don't say it as a urethral opening. It can be urethral or urogenital sinus.
Yes,
both
it can be combined both.
It can be combined.
So any comment, Vagish?
I think that's fine. Only thing is, based on the different positions of the urethral opening, the degree of evaluation also depends. Many a times we see hypospadiasis, and some parents will come and ask for whether evaluation is required or not. So you need to know which hypospadiasis needs to be evaluated, which need not.
And apart from these two conditions, partial androgen insensitivity or file for death, any other possibility?
Yes, 17 beta HSD3 is a possibility, or partial gonadal dysgenesis can be a possibility, and also
so what favors diagnosis of partial 17 beta HSD? History wise, what favors diagnosis 17 beta HSD, which is not there in other conditions?
Sir, in this patient, sir?
Yes, in this patient. Like you said, 17 beta HSD, so we can keep 17 beta HSD. So there is some history which favors.
So degree of genital ambiguity.
And which doesn't favor 3 beta HSD.
So, adrenal insufficiency is not
Yes,
there.
yes. Normal adrenal insufficiency is expected in most of the cases of 17 beta HSD. So that favors, but other condition like 3 beta HSD or 17 alpha hydroxylase seems very unlikely in this
So
case.
hypertension is not.
Yes. And what about 1720 lyase, isolated 1720 lyase deficiency?
So isolated 1720 lyase deficiency, sir, this can
They
occur,
have
but
adrenal insufficiency.
so they do not have adrenal insufficiency. They may have, sir, methemoglobinemia due to the reason because of cytochrome B5 deficiency that they can have, but they do not have any adrenal insufficiency.
Yeah, so that's also favorable right now. And degree of hyperpigmentation favors a condition where we expect that at some point of time there is elevated ACTH.
Yes, sir. Yes, sir.
It's a clearly pigmented genitalia.
Yes, sir.
Yeah, Nagesh, we can go ahead.
Yeah, I think what's the specialty of 3 beta HSD2 deficiency?
Sir, it can present with ambiguous genitalia in both male and female, sir.
Yeah, it can present with ambiguity in both sexes. Fine.
Yes, sir.
So how?
Sir,
see, one is an androgen.
Sir, 3 beta HSD2 in, sir, one is that in case of 46XY DHD, so the androgens level will be low. That is one reason. And in case of the ambiguity in 46XX, actually the 3 beta HSD1 is activated. This will lead to increased androgens, and that might lead to ambiguous genitalia in females. 46XX, sorry.
This is the one condition where both sexes can have a
POR, sir, in POR also, sir, it can occur.
Correct. Yes, you can. So at the end of history and the examination, still we are considering 46XY DSD, possibility of T action defect, fine, or a T synthetic defect. Still it's possible. 5 alpha and partial androgen insensitivity is the major forerunners.
Yes, sir.
Yeah.
So cardiovascular system, there was within normal limit. Similarly, neurological system examination was also within normal limit, and there is no palpable abdominal lump present.
Yeah, just a minute. Dr. Parth, now, why you are looking for abdominal lump?
Good afternoon, sir. So the abdominal lump we look at for when genes are involved in cases of WT1 genes are involved, then there can be abdominal lump present with when there are renal masses in cases of Dennis-Dash, Frazier or Vagus syndrome, sir.
Subhashish has given one more history ruling out these conditions. What was that?
Sir, no frothing of urine,
yes.
Sir had mentioned.
Yes. So because both of these conditions are associated with glomerulosclerosis,
right?
So resulting in chronic renal impairment, so proteinuria is expected, and that's why it's always good to check urine examination as a part of workup for ambiguity.
Right, sir. Right, sir.
Go ahead.
So coming to the investigations, the hemoglobin was 12.4 gram per cent. The WBC count was within normal range. Sodium was 138 millimole per liter. Potassium was 4.9 millimole per liter. Urea was 24 milligram per dl. Creatinine was 0.4 mg per dl. And according to the modified Schwartz formula, the eGFR was 92 ml per 1.73 meter square.
No, I think
we can stop here.
We can stop. I think yes, fine. How we would have evaluated at birth and how the evaluation would have changed at the end of 3.5 years? If this baby would have come to you at the end of 1 month, I think they noticed at the end of 1 month, then they came to you. How would have your evaluation? How this differs when it comes at the end of 3.5 years? If there is possibility you could have seen at birth and also at now also.
So actually at the evaluation will be more or less same, and
no.
However,
what is the difference at 1 month and 3.5 years?
That 1 month the child will be in mini puberty, sir. So
yeah. That makes
there will be no requirement of some maximum chances will be in mini puberty, so that there will be no requirement of HCG stimulation test.
Yeah.
So all these cases of DSD will enter into mini puberty?
No, sir. Not like
So who will not enter into mini puberty?
in 46XY, says KAIS means complete androgen insensitivity syndrome will not enter mini puberty. And for similarly for 46XY, any hyperandrogenic condition like CH and also they will not enter mini puberty.
I think complete androgen insensitivity, they will enter into mini puberty, but they will have a different elevation. But what are conditions you need to have a mini puberty? What conditions you should have in a test gonad? So that can cause mini puberties. You have to have a capacity to synthesize gonadal steroids. If there is no gonadal steroids, you will not have mini puberty. So there are many conditions where gonads are dysgenetic. In that case, you may not have mini puberty.
Yes, sir.
So what are these conditions?
Sir, in complete gonadal dysgenesis, sir.
Yes. Complete gonadal dysgenesis and severe form of ovotesticular disease. All of ovotesticular disease, there will not be any rise in gonadal steroids. So clinical effects of mini puberty will not be there. You can have biochemical effect, but not clinical.
Yes.
And what happens to hypogonadotrophic hypogonadism, mini puberty?
So it is not there, sir.
What happens in hypergonadotrophic hypogonadism?
So mini puberty is there, but sir, not up to months, not like normal.
Hypergonadotrophic hypogonadism, mini puberty comprises of both biochemical
sir. LH levels will be high, but there will be no, sir, mini puberty will be there. Means the effect of mini puberty will be not there, sir.
Yeah, so whenever we describe mini puberty, always remember mini puberty will not be seen in many of these cases. So not essential, but yes, by 1 to 3 years or 3 to 5 months, we can have mini puberty.
Yes.
So how do you want to evaluate at this stage? What test do you want in this patient?
So you are asking next person or Subhashish?
And I think Nitesh.
Next person.
Yeah, Nitesh and Jiban.
Sir, good afternoon, sir. It's Jivan.
Yeah,
sir, at this moment, sir, we should go for a karyotyping, sir. And
straight away you will go for karyotyping, which is not easily available, which is costlier. Our textbook mentions karyotype first, but we are endocrinologists, so our strong fold is endocrinology.
Sir.
So would like to do some investigation.
Sir,
and whenever you are planning investigation, keep in mind we are investigating a 3.5 years old child, not 9 or 10 years.
Sir, considering, sir, gonads are palpable, sir, assuming that
gonads are palpable, whether it's ovary, ovotestes or testes, they are palpable.
Sir, so we can go for, sir, for a basal LH, FSH and testo, sir.
Okay,
yeah, go ahead, Vagish.
Yeah, their testo is because 3.5 years there will be in gonadopause, it will less, all or less. What will you do?
Sir, next we can go for, sir, HCG stimulation test.
Jiban, just a minute. At 3 years, 5 months age, in which condition do you expect abnormal LH, FSH and testosterone? Because it's a gonadopause state.
Sir.
Which condition?
Sir, in gonadal dysgenesis, sir, there can be slight elevation in LH and FSH.
So can we differentiate this slight elevation?
No, sir.
We do not have any cutoff.
No, sir.
So where you will find the clear diagnosis by LH, FSH and testosterone now?
During, sir, at this moment, sir, at
yes.
3.5 years. At 3.5 years, sir.
Yes.
Sir, if Sir, if it is somehow a case of CAH, sir, and
CH, how will you differentiate CH from LH testosterone?
no, sir.
And CH history was pretty clear.
Ridiculous.
Well taken history that we didn't see any
crisis.
Adrenal insufficiency history and examination. Although examination wise there was evidence of increased ACTH effects.
Sir, it will be very difficult, sir. From basal reports, we cannot judge anything, sir.
Yes, would be very difficult, but only in case of complete gonadal dysgenesis, you may have elevation of LH-FSH, but otherwise in most of the condition, you may not differentiate on the basis of LH-FSH level alone or with testosterone.
Sir, sir, then
What
sir,
else?
Yeah.
Sir,
What other endocrine investigation?
Sir, we can go for, sir, HCG stimulation test, sir.
Okay, before HCG, would you like to do something else, biochemical?
At this stage, sir.
Although history-wise we have ruled out, but still possibility, it's always better to rule out by serum cortisol and
Yes,
17 OHP. Routine common investigation, and these common conditions in any DSD, if you see exam, if you make diagnosis of 21 alpha hydroxylase, 60-70% of time you are correct. So these are the common conditions, so always better to rule out.
Okay, sir. So cortisol and 17 OHP, sir, we can do. Okay.
So why not 17 OHP alone?
Sir,
in which condition you are expecting that both will be low?
Sir, both will be low in, sir, if it is a case of either star or side chain cleavage enzyme defect, or in both of them.
Star, you are seeing a good amount of androgen effect.
Sir, less
if it's
likely.
a star, then from
No,
where
sir.
testosterone is coming?
No, sir.
Testosterone is product of cortisol synthesis only.
Yes, sir. Yes, sir.
So from where that testosterone is coming?
Sir, for our case, sir, both cortisol and 17 OSP being low is very less likely, sir.
Unlikely that both would be low.
Sure.
So suppose if you want to allowed to do one investigation only, then which one would you do?
The 17 OHP, I will do.
Yes, yes, that's correct. 17 OHP has more predictability of reaching to some diagnosis. So name few conditions where you will see high 17 OHP apart from 21 alpha hydroxylase.
Sir, in 3 beta HSD, sir.
Yes.
2 deficiency.
What else?
11.
OHP,
I think we have asked you too many questions. Next one is Pooja.
Hello. Yes, sir.
Yeah, Pooja. So add few conditions where you will see 17 OHP apart from 21 alpha hydroxylase.
So 3 beta HSD 2 deficiency.
Yes, correct.
And,
What else? One condition we have discussed some time back. 17 beta HSD is another condition.
Yes, 17 beta HSD3. Yes, sir.
And although rare, but just to complete it, in 1720 lyase deficiency, you can have elevated in POR. Oxidoreductase deficiency also, you can have elevated 17 OHP level.
Yes, sir.
Yeah, Vagish.
Yeah, I think any other biochemical test which are not doing very widely, but it is available, which will be very useful in the evaluation. Basal, most of the things stimulated and all will be useful. So this is at basal also it will be useful for diagnosis.
AMH level?
Yeah, AMH level. How it will be useful?
Sir, it will help to differentiate between, sir, gonadal dysgenesis group and, sir, androgen that pies, that two more common DDs. If we find that AMH level is on the lower side, then it will favor towards partial gonadal dysgenesis. If they find that the AMH level is on the normal or higher side, then gonadal dysgenesis is ruled out. It may be a case of androgen insensitivity syndrome.
Yeah, it's a T synthetic defect or an action defect with your AMH being normal. Yeah, that's being not widely used. I think this is a one good thing to use. So
Yeah,
what's the advantage of AMH over testosterone?
Sir, advantage of?
AMH using other testosterone. Now more of recommendation is coming to measure AMH wherever it is feasible. See, if testo is normal, you just know that all your production and action is totally normal, your thing. But sometimes the assays are not very specific in the neonatal period for a testosterone. So they say that probably AMH is probably much more indicator than the testo, but as of now we are not widely using AMH because of non-availability. What about in your center, Rajesh? AMH?
Absolutely no experience because we are not using, and the simple reason for not using AMH is there is no cutoffs, there is no range, no interpretation. Even if you get absolute value, it would be difficult, like Subhashi said, that lower levels. So how do we define lower? We do not have AMH levels in all these conditions. Not even normal children we have AMH level. So again, maybe a good investigation once we have all these cutoffs and guidance. But right now, difficult to decide seeing AMH level.
Right.
Yeah, we can go ahead. So not much time is left.
Yes. No, investigation, biochemical investigation, you show it, not the karyotyping. Go ahead. Yeah. Yeah.
These are the hormonal investigations which have been done. And in the year
based on the 1 month value, what are your assumptions?
So the child was in mini puberty, the LH was in the higher range, and the testosterone, although not sure that I can call it normal, but it's fairly good at this point of time, 220 nanogram per TL. And so that we can say that there is adequate testosterone synthesis is there, at least for the time in the mini puberty phase.
And which part of your history goes with this testosterone? You have taken one particular history?
Sir, two histories are very important. Sir, one is the descent of the testis in the labioskrotal fold, and another one
No. One history you have taken which goes well with this testosterone level. You have taken history. Mother told that there are some increase in yes. So that yes. So
mini
this
puberty
2.2 nanogram per ml shows that yes, there is good amount of testosterone which might have caused increase in the pelvic size. So even you get a good amount of testosterone at mini puberty, and mother has noticed that there is increase in phallus size. So still you believe that there could be androgen receptor defect?
It's unlikely, sir. Or if the defect is there, it's a very minimal defect, sir. Actually, it's very much unlikely that androgen receptor defect will be the cause.
And this history again do not coordinate with that genital ambiguity, which shows that there is a large amount of, although there was an initial part of testosterone secretion was okay, but later part there was a grossly deficient testosterone level.
Yes, sir.
Because there is absolutely no labioscrotal fusion. And your this is at the second investigation at 3.5 years of age.
Yes, sir. This is the patient after. So recently, the patient is admitted also till now, sir, and we are evaluating further. So these are the investigations after admission, sir. Now.
Anything has been done further apart from this investigation?
So genetic testing has been done, and so this we have added actually post HMG stimulation. So we have done actually for 150 international unit of HMG we have given for consecutive 3 days, and after 24 hours we have looked at the estradiol level.
So day one
must have done this HMG stimulation test, but as a point of this case presentation, this doesn't feature much till now.
Yes, sir. Yes,
Till now,
definitely,
that
sir,
maybe
definitely,
with the final diagnosis.
Yes, sir, exactly, sir.
Yeah. So anything else would you like to do along with these investigations? Who is next? Nishchita, are you there?
Yes, sir. Good evening.
So what else would you like to do?
Sir, doing a HCG stimulated testosterone, DHT and androstenedione would still be like without the karyotype, we could go ahead with an STT stimulated test, sir.
And what's your comment on ACTH level?
ACTH is high, sir.
And this high ACTH in presence of normal cortisol. Plus hyperpigmentation.
Yes, sir.
So how do you join all these together? Anyone else?
Sir,
yeah, Jeevan, you can tell.
Yes, sir. It may be some partial enzymatic defect which led to which is being compensated by elevated ACTH, sir. So some degree of CH, some variety of CH may be a possibility.
So
compensated by the degree of elevated ACTH.
So what would you like to do next?
Sir, in this case, sir, we can 17 OHP can be done, or else ACTH stimulated steroid profile can also be done.
Yes, yes. So ACTH stimulation test, although ACTH is 60, not very high, but still we can do that to rule out associated adrenal insufficiency, because there is a hyperpigmentation, the ACTH levels are high. Although it's very difficult to rely on single ACTH report, it's a ACTH which likely to fluctuate even if the collection conditions or transport condition are not followed, maybe. But cortisol levels are good, so that gives sufficient that there is no major degree of adrenal involvement where cortisol synthesis is affected, and there is no history also, so good amount of cortisol function is there. Although not listed here, but still would like to do 17 OHP.
Okay.
So, yeah, Vagish?
Yes, yeah, I think more than your biochemical test take a time, your karyotyping takes the time. I think what is available for us immediate is your radiological colleagues. Fine. Is there any radiology has been done, and how it will be useful? I think you have to unmute yourself, Subhashish.
The imaging has been done. So ultrasonography was done initially, which showed bilateral testis-like structure in the labioscotal region, and they could not comment on the Mullerian structure. Then MRI whole abdomen with pelvis was done, and there they mentioned that spermatic cords could be traced to rudimentary scrotal sacs, and in the rudimentary scrotal sacs they found mildly hyperintense nodules surrounded by fluid signals intitubated, and short-term inverse recovery images measuring 0.39 into 0.35 into 0.64 centimeter on right and 0.26 into 0.46 into 0.64 centimeter on left.
So what is most important finding
here?
Yes.
What is most important finding?
Sir, that there is presence of testis in the region and there is no Mullerian structure.
Not important. Not
Mullerian
important. MRI cannot show that whether it's a testis or ovary or gonad. Difficult.
Yes,
So
Mullerian
what
structure
is
is
most
not
important?
there. Mullerian structure is not there. Sir.
Yes. That's the most important finding. And absence of Mullerian structure suggests that there was secretion of anti-Mullerian hormone in early part, which comes from Sertoli cells and which comes as early as 7 to 8 weeks. So this suggests that by 7 to 8 weeks, testes were functioning, gonads were functioning, and gonads had definite evidence of that they contained testicular tissue, functioning testicular tissue. It may be over testes, it may be testes, but it's a functioning testicular tissue. So this is most important finding. And now what's diagnosis? Does this absence of Mullerian structure goes well with our initial diagnosis or not?
Yes, sir, it goes well with our initial diagnosis, sir.
Yes, it goes well with that. And rest of the findings also support the diagnosis of deficiency of testosterone in the later part of pregnancy between 8 to 12. So maybe around 11 or 12 weeks, there was deficiency of testosterone. So there was no complete fusion.
And also prostate gland, what is the importance?
Sir, in prostate, actually, if the prostate is not visible, or then it goes in more favor of, sir, in 5-alpha reductases, because for the development of prostate, which is a part of a major Wolffian structure, for the development of the role of DHT is more compared to testosterone per se.
No, even when androgens, when testo is less, also you'll get a lesser production of a T. It will go both ways. So there is a defect in the later part of the your 10th week or a 12th week. The androgen is less, so that DHT conversion is less. Prostate is not well formed. So when you have got a clear cut, testo is normal, well, prostate is not well developed. Yes, I think clue towards the 5-alpha reductase is much more clearer.
Yes.
Yeah. Fine. Do you get a similar picture? Everything is same. Gonads are descended, but if you see a Mullerian structures, what will be your thoughts?
So with ambiguity or without ambiguity, sir?
Same patient.
Same thing, same picture, but
so
you'll get some
Mullerian structure. Gonads are descended, sir.
Yeah, gonads
same patient,
same picture.
plus Mullerian structure on MRI.
Yes.
Sir, it can be over testicular DHD, sir.
No, both have descended well. Still much more simpler one.
Persistent Mullerian duct syndrome.
Yes, PMDS is one of the possibilities.
Sir, ambiguity will be not there, no?
Which one?
Ambiguity will not be there.
Yes, PMDS you won't find ambiguity, but dysgenetic testicular tissue you may find.
Yeah, yes, sir. That's right.
But again, problem is if you find this degree of ambiguity which suggests that there is a clear androgen effect, then it's very difficult to find Mullerian structures because MIS is secreted in the earlier part of the testicular development. So difficult to believe that MIS has not secreted, but testicular testosterone is secreted. So there may be either MIS comes from Sertoli cells, so there may be isolated defect of the Sertoli cells with lesser defect of LH during this Leydig cells during early part of illness.
Or AMH receptor defects.
Yes.
So that's
yes.
Fine. So can we go to the next?
Sir,
we are nearing our time period.
Yeah, so, I think karyotyping is the one last slide. I think.
Slides are actually. So this is the karyotyping.
Are you surprised by this karyotyping?
Yes, sir. I'm so pretty surprised, sir.
Okay. What will you do?
Yes, sir.
No. If you're surprised, what will you do?
Sir, 30-cell karyotyping has been done, so we can go for 100-cell karyotyping to look for any mosaicism is there or not.
Okay, then see, you're all through. You are discussed that there is a functional testicular tissue, but when karyotype comes, there is just XX. There is no white tissue is seen.
Yes.
what will you do?
So then we have to actually think back our diagnosis. We have to look back and think of such conditions in which this can occur, sir.
No, I think, see, this is the one where 2 + 2 = 4. Testicular functional testicle tissue is there. Your Mullerian structures have disappeared. Androgen action is there. There is some amount of development of the penile structure. Gonads have descended. Only you have to find where is the Y.
Yes, sir. So we can do a fish to look for the Y, sir.
Yeah, yes.
But
that is the fish is the one we should do it to search the Y.
Sir, actually, sir, fish is not available. So we have actually done, sir, we have done a MLPA, sir. The SRY and this MLPA, sir, they uses probe for Y chromosome and they uses the SRY, who is one of the among the total 4 probes, I think, sir, for the Y chromosome. They use a probe for SRY. So we have looked, but sir, there was no Y chromosome marker present, sir.
I think I'll be looking for with fish for a Y in this patient, given a choice.
Yes, sir, definitely.
What about you, Dr. Rajesh?
Yeah, I think we have reached to our time. So still, even if genetics are there, clinically and biochemically, our diagnosis with bilateral descended gonad with no adrenal insufficiency, with evidence of, now we have clear evidence of function of testicular tissue.
Yes.
Because there is no Mullerian inhibiting substance secreted in early part of illness, but there is no Mullerian structure, but a good amount of testosterone secreted, which become deficient. So still would like to go for clinical and biochemically 46XY DSD with possibility of 5-alpha reductase or partial androgen insensitivity, more inclined towards 5-alpha reductase deficiency than partial androgen insensitivity. But this is totally surprising findings. 46 must be among few case reports.
Yes, sir. It's actually, sir, just genetics, sir. And this was the genetics, sir. The SF1 mutation was found in the exon 4 region.
Yes,
sir. And
now 5A is SF1.
Yes, sir. And it's,
so this is totally surprising, and there must be only few case report.
Yes, sir.
Must
A
publish
few number of
this
few. Yes, sir.
Fine. I think you need not reach the correct diagnosis. I think your clinical examination, biochemistry should be end in the thing. This will be a Googlean. This will be, anybody can miss it.
Yes.
Everybody will miss it.
Everybody can miss it.
Even you show us this case, 101% we will miss. We will never keep a possibility of 46XX seeing clinical conditions.
Yes, correct.
Clinical and then biochemical also.
Yeah. Yes. I think it will be 46X DID. This is only a genetics is a googly in the end. That shouldn't hinder your clinical diagnosis, clinical discussion in the line of XY-DSTN.
Yes.
Yeah, Bhagesh, I think we are reached to our time.
Yeah, I think we are sharp 6. Yeah.
Thank you.
Thank you very much, everybody. And I must appreciate you people all. You might have read, even then you gave almost all answers.
Yeah, true.
And Subhash, it's a good complete workup of case.
Thank you, sir.
Okay.
Over to Soumik.
Yes, sir. Thank you. Thank you. Our heartfelt thanks to both Professor Rajesh Khargawat and Professor Vagish Iyer for teaching us how to safely navigate through the stormy sea of an ambiguous genitalia case. So thank you again. And we now move over to the next part of this year's EEP 2022. And it's the much anticipated Endocrine Hawkeye. Now, the Endocrine Hawkeye has been a very popular event over the last 4 editions of EEP, and we hope that this year, the 5th edition of Endocrine Hawkeye, will be as exciting as it has been over the last 4 years. The Endocrine Hawkeye is basically a quiz, an endocrine quiz contest, where you need to have the eyes of a hawk, but you need to think like an endocrinologist, a mature endocrinologist. And just to kick off the proceedings, I would like to say that this, like every other year, the winner of the Endocrine Hawkeye will get the coveted title of the Endocrine Hawkeye for the year 2022. And of course, there are monetary prizes as well. 25,000 rupees for the first winner, for the first prize holder, for the one who gets the title of Endocrine Hawkeye, 15,000 rupees for the first runner-up, and 10,000 rupees for the second runner-up. To conduct the Endocrine Hawkeye, I'll have with myself my co-quiz master, Dr. Parthopratim Chakraborty, who is a faculty at the Department of Endocrinology at Medical College, Kolkata. And I've already introduced myself. I'm Dr. Shoumik Goswami, a faculty at the Department of Endocrinology at NRS Medical College, Kolkata. The rules of the contest are simple. The most important rule is that this contest is exclusively open only for the students, the postdoctoral students in endocrinology. Consultant endocrinologists, pass outs who are listening to this program through the listeners link, through the observers link, can test themselves, but please do not submit your entries. You are not a part of the competitive part, the prize taking part of this Endocrine Hawkeye. Students are exclusive participants for the Endocrine Hawkeye. It's very important that you write your name and the name of your institute on a piece of paper, a white piece of paper. Anonymous entries will be summarily rejected, so you have to have your names and your institute's name written particularly. Mr. Anand Mehta, you have his number on the screen, you have his WhatsApp number. That is the number where you need to send in your entries. There are 27 questions for this year's Endocrine Hawkeye, so you write down the answers from number 1 to 27 with proper numbering. Because in case you miss a answer and you write the wrong answer in a different number for the next question, say there's a frame shift mutation. In that case, all your subsequent answers will be marked incorrect. So we'll not take any responsibility for that. So write down the numbers properly. It's important to note that you get +2 for a correct answer, but there's a negative marking -1 for an incorrect answer. So be careful while answering, because you are fighting for the coveted title of Endocrine Hawkeye. And of course, there are prizes as well, financial prizes as well. And as I said, time is limited. Once the 27th question is asked, we'll wait for a minute after that. A minute after that, I'll be giving a signal after which entries will no longer be accepted. Only 1 minute after asking the last question will entries be accepted, and all entries should be sent to the number that is there on your screen, the number of Mr. Anand Mehta. I'll be flashing this number right at the end of this quiz as well. So without further ado, I hand it over to my co-quiz master, Dr. Parthopratim Chakraborty. I think he needs no introduction. He's a popular quiz master in academic circles across India. There will be 27 questions. The first 14 will be asked by Dr. Parthopratim Chakraborty. I'll take care of the last 13, and after the questions have been asked, we'll be discussing the answers as well. So over to Dr. Chakraborty to kickstart this year's Endocrine Hawkeye.
Thank you, Swami. A very good evening to all of you. I hope you are ready with the pen and the papers, right? So do I start, Swami?
Yes, definitely.
So, yeah. So the first question of EEP 2022 is, which is not associated if someone self-injects insulin in such a way? So there are 5 options. I won't be reading out the options. So you identify or you pick the wrong one. Which one is unlikely to be associated if someone self-inject insulin in such a way depicted in the picture? Errors of insulin therapy is not uncommon, and we often come across patients injecting insulin in such a way. Shomik, how much time do we give? 1 minute or half a minute?
About 30 seconds, I think.
Okay, okay. The next one, Somik. Fine. One of the picture on the left side was taken at presentation, and the other one on the right side was taken 2 years post-treatment. So you need to identify the modality of treatment. On the left side was taken at presentation, the second one 2 years after therapy. You need to identify the mode of treatment. Question 3, a bit long one. 37-year-old female, an executive of a multinational company, presented with proximal muscle weakness and diffuse bone pain. The calcium was 9.8, corrected calcium of course, phosphate 1.7, PTH 49, and a vitamin D of 20 nanogram per ml. So with a clinical diagnosis, the resident did an X-ray of the pelvis, which is given, and then expectedly was advised 68 gallium DOTA knock PET CT. The one on the right side is a functional scan, and you can see the fusion SPECT CT on the lower panel. One, the AP view, and the other one is lateral view. So now you know the diagnosis: female, muscle weakness, bone pain. You have the X-ray, you have the functional and the structural scan. So what would be the next logical step? There are 7 options. You have to pick up one. Repeat the scan immediately. Give oral phosphate and calcitriol for indefinite period. Surgical exploration of left upper thigh. Cinacalcet for indefinite period. Total pathectomy. Bruzumab initiation. She can afford that, or a repeat scan after 6 months. I think, go back to the previous one, Somik. Are we done with 30 seconds? 30 seconds? I think it's okay. No. Go back to the previous one. Previous one. Yeah, that was question 3. Keep it here. Question 4.
Shall I shift to the next one?
I think you can.
Okay.
The next one. Okay. Question 4. 53-year-old female was on levothyroxine 100 microgram for quite some time because of primary autoimmune hypothyroid. Suddenly, she presented with increasing neck swelling, hoarseness, and some amount of dysphagia. The TSH was mildly elevated despite being on 100 microgram of levothyroxine. The anti-TPO was positive in very high titer. The clinical examination revealed a diffusely enlarged firm nodular goiter with retrosternal extension as evidenced by a positive Pemberton sign. The FNAC was done. It was Bethesda 1. The clinician was not satisfied with FNAC. He did a core biopsy that revealed fibroinflammatory lesion without any Hurdle cells. The pictures on the upper panel are from ultrasonography, and the one from the picture on the lower panel is a CT scan. T stands for trachea. So this is the clinical and the radiological imaging. The question is, what should be the first line of treatment in this lady? Total thyroidectomy, high dose corticosteroid, external beam radiotherapy, or rituximab. For 45-year-old female presented with some amount of hyperandrogenism and oligomenorrhea for the preceding 6 years. She had no stigmata of cortisol excess, but the modified Ferryman-Galway score was 19. The baseline AM cortisol was 16.4. 17-hydroxyprogesterone was 0.23 nanogram per ml. The prolactin was 42. All the androgens are elevated. The testosterone was 600, DHEAS 148, and the androstenedione was 480. He underwent overnight dexamethasone suppression test with 1 milligram of dexamethasone. The values are after ONDST, the cortisol was 1.5, and there was no significant reduction in the androstenedione, testosterone, or dehydroepiandrosterone sulfate. There are 3 pictures. The CT scan revealed an adrenal adenoma, a nodule with a pre-contrast HU of 5. The size of the nodule was 18 millimeter. Because of the prolactin, MRI of the pituitary was done. The abnormality has been shown by the arrows. And someone also did a MRI of the pelvis, and the relevant findings have also been pointed out by the arrows. So you have a 45-year-old lady with hyperandrogenism and oligomenorrhea, and you have 3 pictures: MRI of the hypothalamus, MRI of the pelvis, and CT of the adrenal. So what is the likely diagnosis?
Partner, we don't commonly see MRI of the pelvis.
Yes,
so,
sir.
So we have 2 longish arrows and 1 a shorter arrow.
Okay. So the longer arrows, they point towards the ovaries, and the shorter one is pointing towards the uterus.
Okay. Thank you. Thank you.
Question number 6. This is from a person suffering from an endocrine disorder. You have to identify the endocrine disorder, the underlying endocrinopathy that might be associated with, that was associated with these findings in that particular gentleman.
And am I allowed to ask what is this investigation on the right?
So on the left side, there is X-ray. In the middle panel, that is CT scan. The third one is CT colonoscopy, CT colonography rather.
Okay.
So you have to identify the underlying endocrinopathy. Next one, Somi. Okay. This lady underwent transsphenoidal surgery twice in 2015 and 2016. She presented to us in very recent past. The MRIs on the upper panel was done in 2019, all T1 SAG. Both the panels in the lower part are taken in 2021. The upper one is T1 SAG non-contrast, the lower one T2 SAG non-contrast. So you have to explain the radiological abnormality observed in the area of interest, that is in the hypothalamo-pituitary areas. So the panel on the upper panel was done in 2019, the lower two in 2021. You have only T1 images done in 2019 and T1 and T2 done in 2021. So you have to explain the radiological abnormality that is obvious in the MRIs. Somik, please go back to the previous one. I think, yeah. Give them some time. Okay, the next one. A 20-year-old male presented with recurrent bilateral nephrolithiasis. Family history was significant because her father died of a neck tumor, and he had a germline mutation of CDC73. The CT scan of this index male was done, the CT scan of the neck. It showed something. We performed a core biopsy from the abnormal areas. And which one do you expect? Do you expect the histology pattern depicted in A or the pattern depicted in B? You have the clinical picture, you have the radiological, the CT scan photo, you have to pick between A and B, which is consistent with the diagnosis. Next one, okay. A 35-year-old male, young onset hypertension. Her father died of metastatic SDHB disease. He presented with right upper abdominal pain, sweating and palpitation. The CT revealed a right retroperitoneal mass of 10.5 centimeter in diameter, and the urinary normetanephrines are sky high. So this is the clinical picture, and with this clinical background, he underwent a 68 gallium DOTA TET scan seen on the left side of the slide. And the clinician was not satisfied with the 68 gallium DOTA TET. He also performed a 18 FFDG whole body PET, which is depicted in the middle panel and designated as A. The patient was treated. After about 3 months. The post-treatment 18 FFDG whole body scan is shown on the right part of the screen and designated as B. So you have two pre-treatment scan. One is 68 gallium DOTA TET, one is 18 FFDG, and you have one post-treatment 18 FFDG whole body scan. You have to identify the modality of treatment. How was that individual got treated? Was it surgical removal of the mass only? Removal of the mass plus adjuvant chemotherapy? Only chemotherapy? Lutetium-177 dotated therapy, or none of the above? So you have to identify the modality of treatment. Question 10, a 9-year-old male presented with limb deformities with a corrected calcium of 9.5, phosphate 3.1, alkaline phosphatase 960, vitamin D 21, and a PTH of 45 picogram per ml. You have the x-rays of the hands, and there is one obvious findings on clinical examination. So you have to identify the defect. You have to pinpoint the defect. What is the underlying abnormality that can explain both these findings?
So we are looking for the molecular defect, the molecular mechanism.
Defect, right.
Not the disease.
Not the disease. Next one, Somik. Okay. So a 25-year-old female, a known case of ALL, or the acute lymphoblastic leukemia, was on dexamethasone, a pretty high dose of dexamethasone, 8 milligram per meter square per day. and she presented with acute abdomen and hypotension. The CT scan, the amylase was high. The CT abdomen revealed a bulky pancreas, but normal appearing adrenals. The treating physician ordered a MRI of the abdomen, and you can see the MRI plates. The one on the time gap between the upper panel and the lower panel was about 6 hours. So you have to identify the condition the patient is suffering from that can explain this radiological abnormality. The time gap between the upper one and the lower one was 6 hours. You have to identify the abnormality that can explain this radiological abnormalities. And to help you, I have pointed out the abnormalities by the arrows. This is a dedicated MRI. And T2 sequences, to be more specific. T2 weighted MRI, a dedicated MRI.
Just to help our contestants, are the different colored arrows pointing to something different, or the same thing is being pointed by different colored arrows?
The colors are different. The red color is different. The yellow color arrows, they point towards some normal structures, and the blue colored arrows, they somehow point towards the abnormalities that gave us the diagnosis. So the normal structure is being depicted by the yellow arrows. The abnormal finding is shown by the green arrows, and the red one is different. The lower panel is different from the upper one. The gap between these two was about 6 hours.
Green or blue? Yeah. Okay.
Next one, Somik. Elderly male, a 75-year-old male, had progressively increasing lower urinary tract symptoms, had fracture of L1 and L3 in the past, in the very recent past to be more specific, presented with acute onset polyuria and polydipsia. The corrected calcium was 10.9, the phosphate was 2.8, alkaline phosphatage was high. Because of acute onset polyuria and polydipsia, a paired serum osmolarity and urine osmolarity was done, and it showed a serum osmolarity of 299 and a urine osmolarity of 128. Someone did a post-EEP urine osmolarity, which was 670. You can see the MRI T1 post-contrast. What is the underlying disease?
And the subject was normoglycemic.
Sir, yeah, sir, the patient was normoglycemic. The disease which can explain all the findings. Question number 13. We have a clinical picture and X-ray, a 6-month-old child reared as male. We got a small phallus and non-palpable gonads. You have to pick up the right option, the biochemical option associated with the clinical and the radiological finding. Whether the child was having low testosterone in 46XY karyotype, high testosterone and 46XX karyotype, a very high TSH, or the child was having a typical radiological triad of pituitary stalk interruption syndrome, or none of the above. So we have to pick up the biochemical or the radiological abnormality enlisted here with that is consistent with the clinical picture and the radiological abnormality. In a 6-month-old child reared as male with small phallus and non-palpable gonads. A 55-year-old male being treated with insulin for long-standing type 2 diabetes. He also had features of microangiopathy in the form of DKD, moderate NPDR. The gentleman was complaining of lower urinary tract symptoms for 5 years, along with sense of incomplete evacuation. The first line test was a uroflowmetry. We have the uroflowmetry data on the left side. After that, he underwent a classical urodynamic study, the findings of which has been shown on the right part of the slide. You have to identify the disease the gentleman was suffering from.
So urodynamic studies also possibly we don't see very often.
Yes, sir.
So if you explain what does PABD, PVES, PDET, what do they mean?
Stands for pressure of the abdomen. PVES stands for pressure of the vesicle or the vesicular pressure, and the PDET stands for pressure of the detrusor muscle.
So what's detrusor pressure and what's vesicular pressure?
So we shall discuss this during the during the explanation of the slides.
Okay. And flow rate is essentially the same as Euroflow.
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
Okay.
So I think I am done with my part, Somik.
So thank you, Dr. Patho, for those 14 questions. We have 13 more questions to go, and as we know, quizzes.
Shomik, I think an important part of this quiz, the Endocrine Hawkeye, is not only to award someone with prizes, which is important, but also to learn from these. So in order to have enough time for discussion, if necessary, I don't know how much time you will take. We should leave at least 20-25 minutes for discussion of the questions.
Sir, we can do the discussion after the end of the next case.
Sir, in case we fall short of time, we can leave at 7 and come back at 8 to discuss the remaining answers.
Okay. Sure. Thank you.
Okay. So we move on to question 15 right away. So you get to see an image of Dr. Frank Gabrin, the first American physician to die of COVID-19. So I need the answer to what explains the Gabrin sign in COVID-19. I do not want to know what the Gabrin sign is, but I need to know the mechanism explaining the Gabrin sign in COVID-19. And of course, think like an endocrinologist.
We can go on to the next.
Yes, sir. So a middle-aged lady was admitted to the cardiac care unit of a hospital, and the cardiologist, after initial evaluation, gave a call to the endocrinologist. You need to identify the condition or conditions which you can make out from the image that is there in front of you. So you have to have the eyes of a hawk and the mind of an endocrinologist.
And I understand, Shomik, that Chinatown is relatively close to your hospital.
Yes, sir. Actually. So the next question, question number 17. Now, you get to see an image of a person to your left, a person who went by the name of Giuseppe Marzo, and you get to see the chemical structure of a drug, the name of which is there on your screen. So I just want you to connect these two. Crinecerfont is the name of the drug, And Giuseppe Marzo is the name of the individual whose image is there on your screen. You just give me the connection between these two entities. So we move over to the next question, question number 18. So you get to see a series of images on your screen. There are two parts to this question, so half a mark for each part. The first part is what is being looked into. Using these three images, what are we trying to look into? And the second part of the question is, other than this imaging procedure that you get to see on your screen, you name two other imaging procedures which can serve a similar purpose of looking into what is being looked into. So you need to identify what this particular investigation is trying to look into, and you need to name two other investigations which serve a similar purpose.
We could proceed.
Yes. Okay. So you get to see images of two different individuals. The one on your left is a famous physician. He's famous. I won't give away his name now. He's famous because he was the first Indian to use insulin, and he used it as early as 1923, just a year after its use began in North America. And to the right is one of his more famous patients who responded excellently to the use of insulin. The name of this girl is Kumudini, who was an individual with type 1 diabetes. The question is simple. I don't want the name of this physician. I just want to know the name of the institution where he did most of his work, including the first Indian administration of insulin. In which institution did this physician work? And of course, we are in the 100th year, the centenary of the discovery of insulin. So we move over to the next question, question number 20. A lengthy question, but the answer I think is simpler. A 16-year-old girl who went to the neurosurgery department with headache was evaluated. You can get to see the MRI images on your screen. And on evaluation, there was a cellular mass for which the neurologist did a biochemical evaluation for her pituitary function. On examination, when she presented to the endocrinologist, she had B3, P1, A0. She gives a history of amenorrhea. And if you look at her biochemical investigations, they are there in front of your screen for you to look into. The question is, as an endocrinologist, what would be the next step or important steps in her management? A 16-year-old girl, headache, found to have a cellular mass by the neurosurgeon, referred to endocrinologist after doing a evaluation, biochemical evaluation of pituitary function. The hormonal values are there in front of you. You go through those values. And as an endocrinologist, what would be your next advice in her management? So somehow question, just a minute. Okay. So for some reason, question number 22 is not visible. No problem. I'll go to question number 22. Sorry, question number 21 is not visible. So we'll have 26 questions in this quiz. Question 21, you can just put a cross mark against it. There will be no marking for that question. So question 22, you get to see two images on your screen. This was a male, a young male who presented with headache. These are the MRI images. The endocrinologist did some sort of a magical intervention, and within 2 weeks, the headache went away, and these are the follow-up MRI images. So a young male presenting with headache, referred to the endocrinologist. The endocrinologist did a magical intervention. After 2 weeks, these are the images. So you need to give two answers. One, what was the intervention that was done? And two, what was the condition that was being treated here? So question number 23. Simple. You get to see a X-ray of the wrist and hand, and you get to see the clinical image of a 6-year-old girl. You give me the diagnosis, the disease rather, the underlying disease. So question number 24. A non-obese 7-year-old girl who was diagnosed to have diabetes at the age of 2 years. And you get to see her blood glucose values over time. The fasting has ranged from 115 to 127. The post-meal has ranged from 125 to 140 milligrams per deciliter. And her A1C values have ranged between 6.5 to 6.9%. Her ultrasound of the abdomen was normal and pancreatic autoantibodies were negative. She has been managed so far with simple lifestyle modification measures. She gives a history of being born with a low birth weight of around 2.2 kgs, and while carrying her, her mother had developed gestational diabetes. Very recently, her maternal grandfather was also diagnosed with diabetes with a fasting of around 138 milligrams per deciliter and a postprandial glucose of around 200 milligrams per deciliter with an A1C level of 6.9%. And on the right, you get to see the inheritance tree of this particular individual. So you just need to identify the disease. We'll move over to question number 25. So two images. On the left, you get to see a pathology, a certain problem in the MRI. You need to identify that. And on the right, you get to see an intervention which was done. And I specifically have put in a white arrow there. You need to identify the intervention which that white arrow is pointing to. So the pathology or the condition or the disease seen in the MRI on the left, and the intervention which is being pointed towards with the white arrow on the right. Two parts to the answer. We have two more questions to go before we'll start discussing the answers. And if we fail to discuss all of them, which possibly we'll do, we'll take up the rest at 8 p.m. after the case number 3 has been discussed. So these are CT scan images of the orbit. And if you look at the image on your right, I'll just go back once. With a red outline, I have marked something, which is a particular sign seen in this condition. So give me the name of the sign seen in this condition.
So they don't need to give a diagnosis, underlying condition. That's too obvious.
No, sir. Yes, sir.
Okay.
We have discussed it already, actually.
And why did you choose the red color, Soumik?
Because on this background, any other color would not have shown through, just to put in a contrast.
I think that is a clue.
Could be. Red or reddish brown. So we move over to the last and final question of this year's Endocrine Hawkeye. And the final question is a movie poster, but it has nothing to do actually with movies. This is a Bengali movie called Chotoder Chobi, released in 2014, which won 2 national awards. And it was based on the tragic life of circus jokers, people performing as circus jokers. It was based on their tragic story. I want you to give me 2 answers. One, which is the latest approved drug for the condition which is seen in this poster, or which most circus jokers suffer from, and the mechanism of action of this drug. It was approved just a few months back by the US FDA. The latest approved drug used to treat this condition and its mechanism of action.
Soumik, I hope you're not being biased towards people of Bengal, because this is a Bengali film. Something is written at the bottom. Hope the answer is not there in the bottom.
No. The answer it's written Chotoder Chobi, which means a movie meant for small people.
Okay, fair enough.
And circus has a global appeal. Circus jokers are the same everywhere. So I think we'll wait for just 1 more minute. So I'll put my stopwatch in action, my mobile stopwatch. And once a minute is over, I'll give a signal. This is the number when you need to send in your entries. I've flashed it at the beginning also. I've given some time for you to save this number. In case of any dispute, as is usual with any quiz, the quiz master's decision is final, and all these questions and answers have been personally vetted by our course director, Professor Shubhankar Choudhury. So in case of any confusion, in case of any controversy, you can always get back to us later to get a clarification. 40 seconds are over, so you have 20 more seconds to put in your entries for the coveted title of Endocrine Hawkeye. And of course, the top 3 contestants would be given awards of 25,000, 15,000 and 10,000 rupees respectively. Just 5 more seconds. 4, 3, 2, 1, and over. I think this is the cutoff. No further entries will be entertained after this. So with that, we come to the end of the questioning part of this year's Endocrine Hawkeye. We'll right over move to discussing the answers. So I'll be flashing the slides once again, and I'll request Dr. Partho Pratim Chakraborty to start discussing the answers.
So the lady was injecting insulin intradermally, and in recent past, intradermal route has been tried as a more effective way of insulin therapy. So intradermal insulin injections are associated with earlier peak insulin concentration, more pronounced peak, and less intra-individual variability. However, as the dermis contains more of antigen presenting cells, the frequency of insulin allergy is somewhat higher. So the right answer for this question 1 would be question point C. So this is the wrong one. Intradermal insulin injection is associated with less intra-individual variability. So the answer to this question is C.
So, but Partho, we have been fighting against people, nursing personnel injecting intradermally. So yes, now sir, you want us to relearn.
Sir, kind of relearning, because intradermal insulin administration by so-called the microneedles with smaller depth is being tried as an effective mode, or a more effective mode of insulin delivery compared to the subcutaneous insulin therapy.
But as of now, we would still be recommending that they inject subcutaneously.
Yes, because the microneedles, the usual microneedles for intradermal insulin therapy is not available widely.
Okay, fair enough.
So you can see on the left, this is a typical case of childhood Cushing's. The localization was negative. So he underwent a bilateral adrenalectomy, and you can see the typical so-called Nelson syndrome. There is significant hyperpigmentation. There is weight loss associated with removal of the adrenal glands. So this was pediatric Cushing's disease. The localization was negative. He underwent bilateral adrenalectomy and developed Nelson syndrome. So the answer would be bilateral adrenalectomy. Okay. So it's a typical case of TIO, or the tumor-induced osteomalacia. You can see the pseudo fracture on the proximal part of the left femur. The resident advised a whole body gallium DOTA knock PET CT and rather a fusion SPECT CT. Now there are two learning points in this slide. Number one, whenever you advise gallium DOTA knock PET CT for TIO, you should instruct that the extremities need to be there in the PET CT, because more often than not, they exclude the extremities while doing PET CT. The other learning point is the fractures and the pseudo fractures may concentrate the 68 gallium DOTA, and you may get a false positive uptake on the areas of fracture and the pseudo fracture. So don't get very excited if you get a positive scan. Please rule out whether there is any underlying fracture or pseudo fracture. So in this case, the ideal step should be a repeat scan, probably immediately, including all the four extremities, because if you look at the functional scan, the extremities are not included in the study, and the commonest location of those mesenchymal tumors associated with TIO are on the extremities. So the answer for this question would be the repeat scan immediately, option A. Okay, so primary autoimmune hypothyroid, if you come across any individual with primary autoimmune hypothyroid with sudden enlargement of the goiter and some compressive symptoms, you need to think of mainly three possibilities. One is definitely primary thyroid lymphoma. The other two are the Riedel's thyroiditis and the fibrosing form of Hashimoto's. However, if you look at this, the biopsy, the fibroinflammatory lesion is not suggestive of primary thyroid lymphoma. And in fibrosing Hashimoto's, you get plenty of Hurdle cells. So though the USG shows hypoechoic pattern, particularly at the isthmus, which has been depicted by the star in the CT scan, you can see the corresponding image in the ultrasonography is showing significant hypoic area. So though these features may be suggestive of primary thyroid lymphoma on a background of Hashimoto's, the histology or the cytology was not suggestive of Hashimoto. In fact, Riedel's thyroiditis mimic primary thyroid lymphoma in many aspects. They are more common in individuals with autoimmune thyroid disease. The radiological features, the clinical pictures also mimic that of primary thyroid lymphoma. So this was a case of Riedel's thyroiditis, and the first line treatment for Riedel's thyroiditis with compressive feature is high dose corticosteroid. So the right answer is option B. Okay, so 45-year-old female with hyperandrogenism. In endocrinology, we know the importance of incidentalomas. In a 45-year-old male, lipid-rich, non-functional adrenal adenomas are not uncommon, so are the pituitary incidentalomas. If you look at the biochemical pattern, the cortisol was suppressed, but the androgens were not significantly suppressed after dexamethasone, suggestive of a non-adrenal origin of the androgens. Prolactin levels were high. Prolactins may be high for a number of reasons. This was basically pituitary incidentaloma. A prolactin level of 42 perhaps cannot explain such a high amount of testosterone. So the lady was having hyperthecosis, in contrast to PCO, where you get hyperintensities from the follicles in T2 weighted MRI. The typical pattern of the typical feature of ovaries in hyperthecosis in T2 weighted MRI is diffuse hypoechogenicity, hypointensity rather. So the two longer arrows, they point towards both the ovaries which are hypoechoic in T2 weighted MRI. The middle arrow showed endometrial hyperplasia in the uterus, and the diagnosis was hyperthecosis.
Partho, once again, we have been taught that testosterone above 200 in a woman would suggest
have hypoestrogenemia, right?
Would have high levels of but we should be looking for a neoplastic cause.
Definitely, sir.
For the high testosterone.
Definitely, sir. But if you look at that MRI, both the ovaries are almost symmetrically involved, and there is typical T2 hypointensity, which is not suggestive of a unilateral lesion, and bilateral simultaneous tumor in both the ovaries perhaps is not that common.
Okay, and such high testosterone is common in hyperthecosis?
Yes, sir. It's not uncommon in hyperthecosis.
Yeah, it's high. Okay. Okay.
Next one, Somi. Okay, so this was the case. On the left side you can see hyperostosis frontalis interna that has been depicted in the middle panel on the CT scan, the bone window. And this is a CT colonography, which is a kind of a virtual colonoscopy in which you can pick up polyps, you can pick up colonic cancers non-invasively. So this modality has been tried in individuals with acromegaly in a non-invasive form of colonic evaluation. So this individual was having acromegaly with doligomegacolon, presence of polyp in CT colonography, and hyperostosis frontalis interna.
So you wanted a diagnosis of endocrine
acromegaly. Yeah. Right, acromegaly.
Okay.
Show me the next one. Okay, so this was basically a case of MEN 1 syndrome, underwent surgery twice. Now, if you look at the MRIs, the appearance has not changed from 2019 to 2021, right? Now, if you come across any abnormalities in the sella or the paracellular or the supracellular region in an individual who underwent surgery, you need to think of two possibilities. One is definitely a residual tumor, and number two is packing materials. Now, if you look at the one on the left side of the MRIs, there is almost no residual tumor, right? And the whatever intensity we get, a soft tissue intensity we see, that is also present within the sella itself. Now, if you think of the different packing materials
within the sphenoid sinus also.
Yeah, to the sphenoid sinus, right?
Yeah.
So if you think of the packing materials, gel foam, they do not last long. They usually dissolve by 6 to 8 months. The materials which persist for a longer period of time is number one, fat, and number two, muscle and fascia. Now, fat would be hyper intense both in T1 and T2, though here the soft tissue mass is T2 hyper intense, that is iso to hypo in T1. So that rules out a possibility of fat as a packing material. The muscle and fascia, with time, they degenerate somewhat, and the intensity becomes iso to hypo, and they become in the long run they become hyperintense in T2. Now the soft tissue here is T1 iso to mildly hypo in some areas, and T2 hyper, suggestive of a probable muscle or fat pack in the sella after surgery.
So, Shomik, can we now offer Partho a designation of endocrine detective? We may have Endocrine Hawkeye and Wise Owl, and maybe endocrine detective will be Partho.
Yes, sir.
Continue. But we have to keep a watch on the time.
Sir, I think we should stop here.
Sir, our examiners are yet to join for the next case, so till they join, we can continue.
I saw Dr. Bipin Shetty having joined. Who's the isn't Dr. Bipin
Bansali is yet
Dr.
to join.
Bansali has to join.
Yes,
so
sir. We'll just
someone kindly call him up and see. Okay, we continue.
So the team is calling him up, sir.
Yeah, sure.
The next one, Sumit. Okay, so this was bilateral nephrolithiasis, history of neck tumor, and the diagnosis obvious, CDC73 germline positive tumor. So basically a HPT-JT. Now if you come across any individual having hyperparathyroidism and jaw swelling, there are possibly two important etiologies. Number one is a jaw osteitis fibrosa cystica on a background of primary hyperparathyroidism, or a HPT-JT. In HPT-JT, the tumor is classically termed as an ossifying fibroma. Now, if you look at the CT, there are some areas suggestive of ossification within the mass. So the mutation was positive for CDC73. Now, if you take a biopsy from the osteitis fibrosa cystica, you get the typical giant osteoclast. The panel A shows the typical giant osteoclasts which are seen in osteitis fibrosa cystica associated with primary hyperparathyroidism. The panel B shows a diffuse fibrous stroma with areas of calcification. The white areas are areas of calcification which has been, the tissue was washed with nitric acid. That's why you get that vacuum on that. So your option, or your right answer would be B. The histology, the B is consistent with the histology of ossifying fibroma seen in HPT-JT. Next one, Sumit. Okay, so this was basically SDHB, the cluster 1A pheochromocytoma. Now, if you look at the guidelines, the test of choice in cluster 1A is 68 gallium DOTA NOC, or 68 gallium DOTA TET. So that was performed, and there was a solitary lesion. However, keeping in mind a possible metastasis, a 18F FDG PET was also performed. The mass took 18FDG, but there are numerous positive uptakes in the mediastinum and in the supraclavicular area. Now, all the cluster 1 tumors, they are norepinephrine secreting tumors, and because of excess circulatory norepinephrine, there is increased activity of the brown fat. They are highly metabolically active, and they concentrate 18FFDG. So the positive uptake you see in the pre-treatment 18FDG scan are not METs, but they are the positive uptake by the metabolically active brown fat. Once you take up the tumor, the brown fat activity comes down significantly in the immediate postoperative period, and the FDG PET will not be shown up. So this was the individual was treated with surgical removal of the mass only. There was the circulatory norepinephrine came down, and the activity of the brown fat subsequently came down. So the right answer in this question was surgical removal of mass only. That is option A.
So both our examiners have joined. So I think we can.
We start from question 10.
Take a break here. Exactly.
Yeah.
So
thank you.
We can take a break here and we'll start from question 10 again. So
good evening, Dr. Bansali, and once again, Dr. Sethi, Vipin Sethi. Yes, please.
Yes. So we'll let the suspense stay for another hour before we declare the rest of the answers. And of course, we'll also let you know the finalists for Endocrine Wise Owl at the end of this case discussion. To discuss case 3, we have with us Dr. Piyash Gorgori, who is a postdoctoral trainee at the Department of Endocrinology at IPGME and SSKM Hospital, Kolkata. And we have two examiners who need introduction anywhere in India. They are two of the most erudite and experienced examiners of our land. We have Professor Bipin Shetty from Hyderabad, and we have Professor Anil Bhansali from Chandigarh. Over to the examiners to conduct the rest of this session, and in the chat box we shall soon get a list of the group 3 students who have joined, who can be asked questions during the case discussion in sequential order. Over to the examiners. Sir, please.
Thank you. I think we will straight away go to Dr. Piyash to ask her to present the case. And then we wait for the list of the participants who can answer those questions. Dr. Piyash, please.
Good evening, respected teachers. And whether I am audible and visible as well.
You are visible and audible both.
Thank you, sir. So, good evening, respected faculties and respected delegates. Today we are going to discuss the case 3, which was provided to me. So a 6-year-old boy who presented with penile enlargement and appearance of pubic hair, who presented in the OPD. He also had, yes sir. So I was discussing that a 6-year-old boy who presented with penile enlargement and appearance of pubic hair in the December OPD. So he presented with voice changes for last 11 months, and he had height acceleration which was noticed by his caregivers since last 1 year. The child, a student of upper KG, was tallest in his class in 2020. However, the behavior of the child was normal. There was no history of headache, vomiting, altered sensorium, seizures, or visual disturbances. There was no history of polydipsia, polyuria, or any history of bedwetting. So, summarizing, this child presented at the age of 6 years with history of penile growth and appearance of the pubic hair, as well as voice bracket, that is voice changes, as well as increased height without any history of headache, vomiting, altered sensorium, seizures, or a central nervous system features. So, for proceeding to the examination, on examination, the child was having height of 119 centimeter, which was more than 97th percentile according to the IEP growth chart, which was having plus 2.5 SDS score. Height age was 7 years. The father's height was 158 centimeters and the mother height was 143 centimeters. The target height was 159.83 centimeter. The target height SDS was minus 2.18. The blood pressure, which was measured by palpatory method, was 90 millimeter of mercury, which was at the 50th centile of the age and height of the IEP growth chart. The child has sparse axillary and mustache seen with a Tanner staging of P4A1 the bilateral testicular volume was approximately 2 ml and the stretched penile length was 9 to 10 centimeter. This was the picture of the child, which you can see that there is a presence of the muscular habitus as well as the presence of the P4A1 Tanner staging as well as the penile length of this child. So, should I proceed to laboratory examination or should I hold it here?
You are supposed to present everything and then the questions will be asked to the other parts.
Thank you, sir. Thank you, sir. So, proceeding to the laboratory evaluation, the child was presented in 2020 when his LH was measured from an outside laboratory was 1.38 MIU per ml, FSH 2.3, and total testosterone was 483 nanogram per deciliter. It was repeated from a separate laboratory. I have coded the lab so that it is not obvious. 2.5 MU per ml is the LH, 0.76 is the FSH, and 631 nanogram per deciliter is the total testosterone. And again, it was repeated from another lab. It was 785 nanogram per deciliter, which was the total testosterone. It was repeated from another lab when the LH came out to be 0.02 MIU per ml and FSH came out to be less than 0.05 MIU per ml. And when it was evaluated and at the Central Institute, it was 0.3 and 0.3 respectively. And the total testosterone was 50 nanomole per liter, which was translated into 1442.1 nanogram per deciliter. And after that, the patient was having treatment, which I will discuss later, which is depicted later. So, others evaluation showed the serum beta HCG was 74.15 microunit per ml, and the CSF beta HCG was normal. There was no obvious lesions in the ultrasonography of the abdomen as well as the testes. The CT thorax and the abdomen was within normal limits. There was no focal pathological update in the PET scan of the whole body. The patient was started with tablet bicalutamide 50 mg, tablet anastrozole 1 mg, and tablet calcium since March 2021. And since November 2021, spironolactone and letrozole has been initiated. So
Thank
this
you.
was
I
the
think
total
that
case.
is the last slide. We don't have the list as yet. I'm waiting for the list of the participants. Can someone send us the list, please? Otherwise, we'll have to ask Dr. P.S. only about the case.
And we have other volunteers.
Yes,
are there anyone
have,
else apart from Pias?
So we have the list now, I think. So we have the list now.
Okay.
Just a minute. So the first question is to Afsar Fatima.
Yes.
Yes, Afsar Fatima. What, on the basis of the finding that you have, will you put as a tentative diagnosis?
So this is a case of 6-year-old boy who has presented with penile enlargement. I would like to think isosexual precocious puberty.
Why do you say it is isosexual precocity, Dr. Aditya?
Good evening, sir. This is a 6-year-old. This is a 6-year-old male child with no history of ambiguity who presented with enlargement of the penis.
So what makes you say it is precocious puberty?
Hello, sir, am I audible? Hello?
Yes, you are audible. Yes, you are audible.
Hello?
Yes, you are audible. Please go ahead.
Yes. This is a 6-year-old male child, male phenotype, but presented with enlargement of the penis at around 5.5 years of age. So I say 6-year-old.
Gopal Dutt.
Now your voice is lost, doctor. I think there is some issue with Aditya's connectivity. Komal, why do you say it's precocious puberty? Komal Sanjay. We have, as usual, a pin drop silence. I don't know whether connectivity. Yes, Komal. Why do you say it's precocious puberty? Don't repeat whatever has been said. Why do you say it's precocious puberty?
Because, sir, the age of the child is 5.5, 6 years old. So,
yes.
And out of the lesser than the third centile for the onset of puberty. So usually less than 9 years of age in boys and 8 years of age in girls, we will take it as precocious puberty. This child
we are interested only in this child. So this is less than 9 years. So why is it not... okay, the age criteria you have said, Sagar, why is it not premature puberty?
Sir, because there is increase in penile length also.
Okay, what else is there? What is the evidence of systemic exposure to testosterone?
Voice changes are also there.
Yes, and what else?
Facial and increase in height.
Yeah, so there is evidence for the exposure to the body tissues other than the genitalia which the parents have noticed, and that is evidenced by acceleration in the height and voice changes. So you are correct in calling this precocious puberty.
Yes.
Alekhya,
sir,
what are the accepted terminologies for types of precocious puberty?
Isosexual precocious puberty, sir.
Yes.
Go
ahead. Can't hear you.
Isosexual precocious puberty, central precocious puberty.
Yes, please go ahead.
Gonadotropin dependent and gonadotropin independent or peripheral precocious puberty.
So, which are the more accepted terminologies? Of course, all of these are isosexual precocity, heterosexual precocity, central, peripheral, gonadotropin dependent, gonadotropin independent. In endocrinology, which is the terminology which is most often used?
Gonadotropin dependent and gonadotropin independent precocious puberty.
Now, Suman, sorry, I'm sorry. Yes, sir. So, Gopal, on the basis of the examination that you have, whatever the findings were, what was the likely possibility in a male child that you have when you found that the child's height is confirmed to be more than 9 centile, but for deciding the dependency or independency, what is the finding that indicates that it might be independent?
Testicular volume is only 2 cc, sir, in spite of SPL being 9 to 10 centimeters. So, in presence of T4, they suggest gonadotropin independent precocious puberty in this case.
Okay, we come back to Afsar Fatima.
Yes, sir.
Can you just show the next slide, Doctor, the investigation slide? Now, when you look at these values of LH, the first two values, is there any surprise?
Yes, sir. At this age, LH is more than 0.03, so it is elevated, sir. Increased LH and increased testosterone.
Are you a little bit unhappy with these lab findings? Are they discordant with your clinical impression?
Yes, sir. Testosterone is very much elevated.
No. In terms of because your colleague just told me that it is gonadotropin independent precocity for basic clinical examination.
Yes,
so when you have two LH values in March and also in May, which are more than 0.3, as you rightly said, are you surprised about it, or you are okay with it?
Yes, sir. In gonadotropin, independent LH and FSH are usually suppressed.
So which one of these you are going to give more weightage to? The lab or your clinical findings?
Clinical findings, sir, mostly.
So what might be wrong with this? Because subsequent treatments, the treatment that has been mentioned never mentioned a GnRH analog. So what might be wrong with this? Aditya.
Sir, exposure of high levels of testosterone may lead to priming of the axis, which initially it might be a gonadotropin independent precocious puberty, which may later turn into a gonadotropin dependent precocious puberty because of priming of the axis by testosterone.
And without treatment, it becomes like that, or with treatment?
With treatment, sudden withdrawal, suddenly if the testosterone levels drop, then there may be a surge in the LH levels because of that.
Apparently, this child did not receive any treatment from the history, whatever is told, till November. So the child was not treated. So what is wrong with the assay? Komal.
Actually, LH and FSH we have to take old assay.
Which assay do you use in your hospital for measuring LH?
So two pooled assays, sir. Three tests, 20 minutes apart we have to do, sir.
No, the collection of the sample is right, but which is the methodology which we use in your hospital for measuring LH?
Yes, sir.
Sir, may I?
And what is the cutoff on that assay for diagnosing or differentiating between the frontal and peripheral?
Sir, if it is more than 0.3 in basal and more than, then we take it as the stimulated.
So do you think that this could be an assay problem?
Yes, sir.
Then Sagar, on 13th of November, the patient had a sampling done and the level was just 0.3 and possibly the GnRH stimulation test was done. Which is the GnRH that you use in your hospital for a stimulation test, and how is it administered? Sagar. Sagar? Madhumita? Have you lost connectivity, or am I lost to you? Sorry? Am I audible? Yes?
Yes, sir. Yes, sir, you are audible, sir.
Why there is so much lag period?
Sir, may I answer those questions?
I thought that you will be in, you know everything. You know, you hold the cap, magician's cap. Yes, which is the assay that you use in your hospital that has been clarified? Which test, how do you test? Supposing this child comes to you, baseline is 0.3, which is, or 0.29, and you want to stimulate, what will you do?
Sir, actually, the first question that the LH level that was discordant may be because of assay interference, which may be because of certain labs use polyclonal antibodies and certain labs may use monoclonal antibodies. So monoclonal antibodies will be a right option here, which probably has been done in later assays. Now the second test is, sir, for our institute, we usually do a leukocyte stimulation test. It is given at the rate of 20 microgram per kg, and after 3 hours, after 3 hours, the blood is drawn, and it is seen that the post-stimulation LH value is more than 5 or not, and it is really taken as a cutoff, sir.
How do you inject? Which route do you administer?
Sir, IM, sir.
IM. Can subcutaneously be given the same injection?
Can be given, sir, but I would not do it.
Why?
Sir, because IM route is more commonly used, but yes, sir, subcutaneous can be used also.
But IM is more painful also.
Yes, sir, that's true also.
No, it may be that it's your institute's protocol, but it's all right. So it's uniformity that is very important. So, do you think that this particular stimulation test showed that there is some stimulability or not?
Sir, I don't think that given the picture here, it will show any form of stimulability because
they have said 0 hour and 2 hours.
Yes, sir.
Both values are same.
Yes, sir. Both values are same. So though they don't show any form of stimulability. So this is, I don't think, sir, that this is a gonadotropin dependent precocity.
So okay, let's say that for a moment that we do not have the 7-11 or 13-11 values at all with us. Yes, we have only the March level and the May level and then the January 22 levels.
Okay.
Would you still say it is gonadotropin independent?
Yes, sir, definitely. Because sir, I would give more weightage over my clinical discretion, because the clinical discretion that clearly shows that there is a clear discordance between the testicular size and the penile length as well as the height velocity. So it clearly points that towards that it is a gonadotropin independent sexual precocity. However, in certain cases, had this patient had got treatment from outside, I would have inquired into it that gonadotropin independent sexual precocity after receiving adequate treatment may turn into gonadotropin dependent sexual precocity. But again, that testicular volume will be again a hindrance, sir.
And in this case, the reverse seems to have happened. If the values were 0.02 and 0.3 are non-stimulable and later on 1.3, 2.5, 1.09, you could have said that something has happened. It is the other way around over here.
Yes, sir.
Then finally, a question to Dr. Gopal. Do you think that HCG value is relevant? Because they have not given the normal values, but what is this HCG value? Is it relevant, positive? Because in endocrinology, unless you give in kilograms, micrograms, picomole, it makes no difference and no sense.
Sir,
what is the normative data is what is important.
Yes, normal beta HCG is less than 2 IU per ml, sir. So
less than 5.
So
this is high.
What is this? And do you think that this might have led to some cross-reactivity for the LHSA? The date is not given. We assume that this sample was done when you had these relatively high values.
Might have led to cross-reactivity.
I will request now Anilji to take it further.
Yeah. Thank you, Vipin, for having a nice discussion on this case of gonadotropin independent precocious puberty. I think there are some interesting issues in this case, because this case we just received 1.5 months earlier with us, and there was diagnostic issues. So I'll just ask the some questions which are relevant to the this audience. Can anyone tell about that? What are the situations where you have a GIPP with testicular enlargement? What are the situations where the GIPP is associated with testicular enlargement?
Sir, any testicular tumors, testotoxicosis?
No, testicular tumor is usually asymmetrical. So that is not a diagnosis. Yes, we use a bilateral testicular enlargement with gonadotropin independent precocious puberty.
Testotoxicosis.
Testotoxicosis.
Macunal break and hypothyroid.
Macunal. So, another cause CH with adrenal rest tumor. There are so many, and SCG secreting tumors. So even in SCG secreting tumors, you can have a testicular volume of even 3 to 4 ml, but still it is gonadotropin independent precocious puberty. So remember some of the causes. Can you tell vice versa, where the puberty is ZDPP and there is no testicular or testicular enlargement is less than 4 ml? So in fact, there are no causes. There is no it because whenever the axis is activated, you will always have a testicular enlargement. And remember, the testicular enlargement is the earliest and the first sign of the native puberty. And the penile enlargement usually starts happening after once the testicular volume of 6 to 8 ml is achieved. So that's a very important in this case that the testicular volume is only 2 ml and the penile enlargement is disproportionate to that. He also had a gynecomastia. Of course, this gynecomastia was the feature once he started on androgen receptor blocker as well as on letrozole, as well as on anastrozole. Suppose someone, a child with a penile enlargement and presents with gynecomastia, what are the possibilities you will think? So it's like a heterosexual precocity in a boy. So what are the possibilities you will think in a scenario of that? Penile enlargement, TB is less than 4 ml and there is a gynecomastia.
Aditya?
Sir, exogenous androgen use, androgen abuse in adolescents, that can cause...
Exogenous androgen abuse may have the gynecomastia, but it is less common. You have a penile enlargement, fine, but it is less common. Other common causes where you have is adrenocortical carcinoma. In that scenario, you can have a penile enlargement with gynecomastia. The Leydig cell tumor also presents with that. And remember, germinoma is a very important cause which can present as a gynecomastia with penile enlargement. The reason for why the T versus SCG, you have a more common predisposition for gynecomastia. That is mainly because the direct effect of SCG on Sertoli cell aromatase activity, which the LS does not have. So that's why the gynecomastia, even in clinical scenario, you see whenever you use SCG in hypogonadotrophic hypogonadism, you see more gynecomastia with SCG than with testosterone. So it's a direct effect of SCG on Sertoli cell aromatase activity, which contributes to more predisposition for gynecomastia. However, in this child, this gynecomastia happened after androgen receptor blocker therapy and anastrozole. Anastrozole is being an aromatase inhibitor, but it's a known suicidal aromatase inhibitor. So that's why the rising testosterone could not be overcome by the aromatase inhibition activity of the anastrozole. That's why he developed gynecomastia on the therapy. There is one more comment about that. His LH and FSH at a baseline were high. High in the sense, it is more than the cutoff which we take is less than 0.3 and more than 0.3. It was high. So it is a cross reactivity you should also check. And the cross reactivity with the ACLEAR which we do by the Roche, SCG and beta SCG and LH cross reactivity is 0.003% or 0.03%. So it's a very minimum. That's why assay done at our lab is only 0.3 and after GNS stimulation it remained 0.3. But if you can also appreciate one of the reasons for that why it did not go up with that, and we are presuming that there might be some transition from GIPP to GDPP because high level of testosterone at that point of time, 50 nanomole per liter, could have inhibited the GnRH pulse generator activity. That might be one of the explanation because now once the testosterone has come down after putting on spironolactone and letrozole, his LH has start again rising. So what I feel now that possibly he is transferring into or transitioning from GDPP to GIP. So I have asked again to repeat this GR stimulation test, Duprolide. As even mentioned intramuscularly, usually the recommended is subcutaneously. After 3 hours with the Duprolide with a maximal dose of 100 micrograms, you collect the sample at 3 hours for LH and 24 hours for testosterone. You can also have a dichotomy. The LH may not be rising to up to 6 or in some studies up to 7, but the testosterone rises after GnRH. So yes, the sensitivity of alone testosterone is low, around 70%, as opposed to rise in LH after LHRH or after GnRH. But still, suppose you don't find LH rises, but a rise in LH is not there, but you find a rise in testosterone, then it is again supportive of a GDP or transitioning from GIPP to GDP. So what I think that because the different labs have given a different assays, and that was I was told by the Tosho system. So I don't know. So the cross reactivity may be there to some extent. So that's why the LH and SCG were LH was measurable in that scenario. But the clinical is I think very clue. And one more comment was the beta SCG is unmeasurable. Beta HCG is unmeasurable in a prepubertal, only in a during pregnancy you can measure. So in a prepubertal child, it is unexpected. The level consistently, there are 2-3 readings of beta HCG, they were high. So that is definitely there was some suggestion of some germinoma. The CSF beta HCG was done to find out the intracranial germinoma. Unfortunately, it was normal. And then PET CT was also done, we could not find. There was some suggestion of a testicular germinoma, but that was also excluded by doing the ultrasound testes. And PET CT, there was some suggestion, but it was ruled out by that. So we could not find out the source of this SCG. However, and he was put on spironolactone plus letrozole. So I think what are the now challenges in this patient? Can anyone predict that? What are the challenges? Because another point I think which was missing in the history was the bone age advancement. His bone age is now 11 year plus. So his bone age advancement was very fast. That's why there is a suspicion of transition from GDPP to GIPP. Oh, sorry, GIPP to GDPP. But we have asked for the tutorial test now, and then we can have this. If it is there, then he can be added with GnRH agonistic analogs along with the spironolactone and letrozole. So I think the message from this case is that you can have sometimes presentations like this. Testicular lack of testicular enlargement supports the diagnosis of GIPP, and you can have even sometimes presentation with germinomas as a heterosexual precocity. So if any questions or any comments by the Vipin, I think you can also add.
Well, I think all in all, the group has done very well because they stuck to clinical findings for differentiating between gonadotropin-dependent and gonadotropin-dependent puberty. Since we have some time, I thought we can ask some questions to Komal. What is the ovarian volume? Ovary also increases in size, only we cannot see it. What is the ovarian volume at which you say that somebody has probably entered puberty? Komal? Shagar? You people agree that ovarian
4 cc maybe, sir.
More than 2.8 ml.
Yes, don't equate testicular volume with ovarian volume.
It's a more than 2.8 ml. That is a correct answer. Less than 1.6 ml is a prepubertal, and more than 2.8 ml is a pubertal.
Alekia, what is the uterine volume?
More than 2 ml is uterine.
And the length?
Volume 3.5 centimeter.
Sir, it is 3.5 centimeter.
3.5 centimeter is considered as the pubertal uterus.
Okay, and so therefore, do you feel that in patients wherein you have some difficulty in of the type and kind that you're encountering in this patient, ovarian volume measurement is going to be useful, Gopal?
So like presence of an ovarian cyst greater than 9 mm along with increased ovarian volume would suggest a cause of GIPP, sir. Like,
no, I think cyst is not being consistent with the diagnosis. I think it goes with the volume. So if the uterine volume is more than 3.5 or ovarian volume is more than 2.8, then it is suggestive of the puberty, entry into the puberty.
Okay.
Okay. What is the mechanism of conversion of gonadotropin independent to gonadotropin dependent precocity? PS.
Sir, actually what happens that gonadotropin independent sexual precocity, the target organs are usually exposed to the sex stress to a pretty long time. Say at the age of, say they comes to say at the age of 10 to 11 years. So when adequate treatment is started, the sex drive levels is suddenly, and that elevated sex drive level actually suppress the generates pulse generator, as has been told by sir. So when the adequate treatment starts, the sex drive levels abruptly cuts down. So that in turn leads to reactivation of the generates pulse generator, and on the background of the primed target organs, the GIPP gonadotropin independent sexual precocity turns up into gonadotropin dependent sexual precocity, sir.
what is the ancient term of testosterone rebound treatment?
Yeah.
It was used in infertility without, of course, much success. But what was the basis of that?
Sir, it was actually the sudden release of the inhibition, sir.
So, and what was when you stop it, it was expected that there is going to be a rebound and you are going to get better gametogenesis, in this case, spermatogenesis, but that didn't quite happen. This actually is also the same thing. That whenever you give supraphysiological dosages and then you abruptly stop them, then that happens. But I think the important message which this case has taught us is that clinical examination. Analysis should go from clinical examination. Otherwise, this patient could have been, if you do not examine the patient properly, he would have wrongly received gonadotropin GnRH treatment. And that would have anyway not led to any improvement. And we are still searching for that elusive tumor, which you would have not otherwise searched for. So if you have a person who is having, there is no correlation between the clinic and the laboratory, go by your clinical findings. I think that's message number one. Message number two is that if you get some abnormal values, please go to the lab. Ask them, this is what is happening to my patient. I don't expect his LH to be high. Can you redo it? Can you do it from a more ultra-sensitive method? And then can you show us what it is? And then you will probably come to this conclusion. So I think this being a clinical round, and I always keep thanking Shubhankar for bringing in. I publicly apologize for the mistake that I did last year. I didn't know that the Primarin can also be used to sort of prime the priming for pubertal for growth hormone assessment. And somebody said that Primarin is used. We used to use only estradiol and also testosterone. So we keep learning from this. But the major learning from this case is that small tumors like that of Cushing's, prolactinoma in women may have florid clinical manifestations without a demonstrable tumor. And this is an issue. Sometimes you have florid manifestations, you keep searching for the cause, you don't find it. That's very, very frustrating. And it is frustrating, all right, but the search for the tumor will go on if you finally look at the patient and rather than the report, because as Dr. Benshali said, now his testicular volume may also start increasing in size. And if you do not know the chronology of events, then you would say it was gonadotropin dependent because puberty all along. If you haven't seen the child before, as was pointed out by Pias, that history of prior treatment is important, and clinical examination at each visit is very important. This is also important for CH children. You are treating a child with CH and the child suddenly starts having growth spurt and he is on adequate treatment, he is 17 OHP, his androstenedione, everything is very well suppressed. Kindly see the patient. If his testicular volume is increasing, he would require, in addition to gluco plus minus mineralocorticoids, a GnRH treatment at that point of time. So I think there is no going away from clinical examination, and I think we need to spend all times and energy scratching our heads if the clinical finding, which is very strong, is not corroborated by the laboratory. Don't blindly trust the laboratory. Tell them this is not the report that I expect, and please do it again. I think with that, I will again pass the thing to Dr. Bansali for giving us a very interesting patient, thought-provoking patient, and this is work in progress. You may be probably foxed by this, but this case is presented to you, tell us that there are other nuances to precocious puberty than the usual ones which you have. It's very easy to diagnose von Wieck-Grumbach syndrome. It's very easy if you look at the skin of the person, look at McEwen-Albright syndrome. Occasionally you may pick up testotoxicosis, but it is relevant and important not to miss out adrenal causes like CH, adrenal tumors, specifically adenocortical carcinoma, because they can lead to lethality if you miss them. And here, if you are not able to make a diagnosis, at least give drugs which can block the androgen production or action or both, and then watch for the things to appear. I think this child will sooner or later show that tumor till such time, whatever treatment is there, but at least he's not left off the hook. And that's what is the message. And I thank Bansali very much for having brought this case. And very solace to all the participants. This kind of patients you will see very, very rarely. Your clinical practice, you will see more of gonadotropin dependent or independent precocities, which are very clear cut, but enough to know that this kind of cases can fox you, and you should be keeping your eyes open for this kind of cases, and don't blindly look at LH more than 0.3. Chalo, GNRH treatment. Manshali.
Yeah, I think Vipin very rightly pointed out the clinical examination is very important, and a consistent finding in this case was the testicular volume less than 4 m. So I think that's why even you have some ambiguity in the assays, but which you should always overcome by the clinical examination. That's a very, very important message which we should, and we should also learn about the intricacies of the assays which are having a cross reactivity between the two hormones. The second point which I would like to summarize in that, suppose even this patient would have had a testicular enlargement of volume of 4 m, but still it was a disproportionate penile enlargement 1. In that scenario, and even suppose the LH would have been 1.2 or 1.3 like that, you should have done a GNRH and ruled it out. So that's why, because if it is an SEG mediated GIPP, then the GNRH response will not be up to the mark. So up to 6 or 8 units per liter, what we say, will not be there. So I think that will require this. And exactly what I mentioned is that now with a decrease in testosterone, again the LH has started rising. So that gives us some suggestion, because the assay is now same by Ackley or Roche. That gives us some suggestion that transition from GIPP to GDPP. So management will be, in this case, will be spironolactone with choice. And after this spironolactone and a letrozole combination, his gynecomastia has receded remarkably. The penile enlargement is constant, but there is no change in the testicular volume. We are waiting for the triptorelin response, and if you find there is a response, then we will do a GNRH agonistic, and we will continue till the age of 11 years. Because after, even if we put them on a GNRH agonistic analogs, you have what this is called as negative. You put on a GNRH agonistic analog, so you have a gain, continuous gain in predicted adult height. So that's the aim of putting on GNRH even with the advanced mode age. So with this, I hand over to Vipin again, and if there are no questions, then, or if there are any questions or comments we can have from Shubhankar also.
No, thank you very much. Thanks for bringing this interesting case for discussion, for both of you for providing your inputs. Thank you. Thank you very much. And we'll see both of you tomorrow, and Anil definitely tomorrow for your talk.
Yeah.
Bipin is not there, but that's okay. But we'll see Anil once more tomorrow. Thank you. Thank you, sir.
Thank you.
He's more charismatic and he's more required. Thank you.
Thank you. Thank you, sir. And sincere thanks from the EEP team for taking us through that difficult case wonderfully, and enlightening our young students with your pearls of wisdom. So we move over back to the answer discussion part of Endocrine Hawkeye, and I request Dr. Partho Pratim Chakraborty to rejoin me. We'll begin from question number 10. We had left our students at that point. So question number, just a minute, I'll start screen sharing. Okay. It's question number 10. Okay. Dr. Partho, please.
Yeah, sure. Thank you. So, anyway, you can see the changes of rickets. So, once you come across rickets, either clinically or radiologically, and the biomarkers, particularly the calcium and phosphate and vitamin D PTH is normal, you need to think of renal tubular acidosis. So in this case, the alkaline phosphatase is high, which is quite common in all forms of rickets, but rest of the parameters are essentially normal. The phosphate might be low normal or slightly low as per the age of the patient. This was a case of renal tubular acidosis. Now, once you come across renal tubular acidosis, there are, in a 9-year-old child, you need to think of primary forms of renal tubular acidosis. And there are certain clinical clues, non-renal clinical clues, which can give you an idea about the underlying genetic defect. For an example, in distal renal tubular acidosis, a primary form of distal renal tubular acidosis, if you come across sensory neural hearing deafness, you need to think of defect in the B4 or the A0 subunit, A4 or the B0 subunit of the hydrogen ATPase. In proximal form of primary renal tubular acidosis, you might get corneal deposits in cystinosis. You may get spherocytosis, elliptocytosis in anion exchanger defect, or you may get chronic liver disease in tyrosinemia, or you can get band keratopathy, which is seen here in the sodium bicarbonate co-transporter defect. So you have to look for the non-renal clues in any child with renal tubular acidosis, be it primary or secondary. So in this case, that child had renal tubular acidosis because most of the parameters are normal despite having features of ricket, and there was band keratopathy. So this was a primary form of renal tubular acidosis due to sodium bicarbonate co-transporter defect. The next one. Okay. So once again, acute abdomen hypertension in endocrine practice, you need to think of primary adrenal insufficiency. One of the commonest cause of non-traumatic adrenal hemorrhage is pancreatitis. Moreover, this lady was suffering from acute lymphoblastic leukemia. So she had 2 risk factors for non-traumatic adrenal hemorrhage. This is somewhat difficult to pick up in the early phase because in the earliest stage of adrenal hemorrhage, the CT scan may be normal. The MRI can give you a diagnosis. If you look at the yellow arrows, the darker sign is pointing towards the normal adrenal parenchyma, the medial lymph of the right adrenal. And you can see a hyper intense area that is suggestive of a hemorrhage. In T2, hyperacute bleed appears bright. So this is called a typical tram track sign of acute non-traumatic adrenal hemorrhage. The appearance is obvious bilaterally. So that lady had bilateral non-traumatic adrenal hemorrhage, which was not evident on CT scan. Over the time, after 6 hours, you can see the lateral limb is somewhat distorted. So now you are going to get the typical features of adrenal hemorrhage either on CT or on MRI. So if you are suspecting acute adrenal insufficiency in individuals who are prone to hemorrhage, you need to think of acute adrenal hemorrhage, and MRI is a kind of a investigation of choice where you come across the typical tram track sign. So that in this case, your answer should be either a tram track sign or acute non-traumatic adrenal hemorrhage. Next one, Somi. Okay. So once again, if you come across enlarged pituitary suggestive of pituitary macroadenoma, and the patient is having central diabetes insipidus, which is obvious on biochemistry, you need to think of 2 possibilities. We all know that a pituitary macroadenoma confined within the cella usually do not give rise to central diabetes insipidus, except in 2 conditions. Number 1, if there is pituitary apoplexy or there is pituitary metastasis. Now, in these 2 cases, there is sudden enlargement of the pituitary. The posterior pituitary kind of goes into a state of shock stage. So you may get central diabetes insipidus. This gentleman had lower urinary tract symptoms, fracture of the vertebrae, mild hypercalcemia, and was suffering from prostatic CA and a pituitary mets. So if someone answers pituitary mets, that's good enough. If someone says maybe guesses that it's a case of prostatic CA metastasis to pituitary, that is also accepted. So the diagnosis is pituitary mets. Once again, if you come across pituitary enlargement and central diabetes insipidus, think of apoplexy, think of pituitary mets. Next one, Somi. Okay. So 6-month-old reared as male, the possibilities are either XX with hypogonadism, with hyperandrogenism, or XY with hypogonadism. Now, you cannot explain this form of radiological abnormalities in XX with high testosterone. High TSH can give rise to ichthyosis and epiphyseal dysgenesis, which may resemble the clinical picture, but in that case, you cannot explain the genitalia which was evident on clinical examination. Now, non-palpable gonads and small phallus are suggestive of hypogonadotropic, in fact, intrauterine testosterone deficiency, be it hypergonadotropic hypogonadism or hypogonadotropic hypogonadism, developing after first trimester of pregnancy. Now, the CUL1 gene is situated on the small arm of X chromosome. There are some other contiguous genes which can give rise to a phenomenon known as contiguous gene deletion syndrome, where you get hypogonadotropic hypogonadism, ichthyosis because of steroid sulfatase deficiency and chondrodysplasia punctata. The X-ray is suggestive of chondrodysplasia punctata. So the child was having hypogonadism in the form of Kallman syndrome and a contiguous gene deletion syndrome. So the right answer would be a low testosterone in 46XY. So if you look at the uroflowmetry, the flow rate is 5 ml. In this age group, we expect a flow rate of at least 15 to 25 ml per second. So there is some obstruction in the flow, which can be because of detrusor abnormality as a part of diabetic cystopathy or because of bladder outlet obstruction. Now, the definite diagnosis can be achieved only by urodynamic studies. Sir was asking about the vesicular pressure, the detrusor pressure. The vesicular pressure is a sum of the abdominal pressure and the detrusor pressure. Now, if you look at the graphs, the detrusor pressure is almost equal to that of vesicular pressure, and there is no contribution from the abdominal pressure, meaning thereby the detrusor was hyperactive. There is no detrusor weakness. And if you look at the lower panel, the outflow graph is kind of a box-like abnormality, which is diagnostic of a fixed outlet tract obstruction. So once you come across low flow rate, you need to do a urodynamic study. If the detrusor pressure is almost parallel to that of vesicular pressure, ruling out detrusor muscle weakness, you need to think of bladder outlet obstruction, and the fixed bladder outlet obstruction gives rise to a box-shaped curve in the flow rate. So the answer would be bladder outlet obstruction. If someone gives an answer with fixed bladder outlet obstruction, that is also accepted. If someone gives only bladder outlet obstruction, that is also accepted. So I think I'm done with my part.
Thank you.
Over to you.
Yes, Dr. Partha. Thank you. And the latest update is that we have received around about 70 entries within the stipulated time limit for Endocrine Hawkeye. So we'll have a difficult time correcting all those answer sheets. So question number 15 was, what explains the Gabrin sign in COVID-19? And Dr. Frank Gabrin, as you can appreciate, he had androgenetic alopecia. It has been seen that individuals who have androgenetic alopecia, who have high androgen levels, have higher rates of hospitalization, increased severity of COVID-19 infection. As an example, on the other side, individuals being treated for carcinoma of the prostate who undergo androgen ablation therapy, they have lesser severity of COVID-19 infection. The underlying mechanism, the proposed mechanism being that there's an androgen-dependent protein called transmembrane serine protease 2, which aids the entry of virus into the cell, just like ACE2. So because androgens increase the level of transmembrane protease serine protease 2, they increase the severity of COVID-19 infection by allowing them entry into the cell. So the explanation behind Gabrin sign is androgen-dependent upregulation of this protein. So that is the answer that I was looking for. Question number 16, if you can guess correctly, or if you look at the image carefully, there's a yellowish discoloration of skin, the so-called carotenoderma, which is a condition which is seen in patients with overt hypothyroidism. As I had said, this lady had landed up in the cardiac care unit with a cardiac tamponade, with a pericardial effusion and cardiac tamponade. In this case, in hypothyroidism, the metabolism of carotene, the hepatic metabolism of carotene is affected. Carotene starts building up. It gets deposited in the stratum corneum of the skin. It is excreted through sweat. Along with sweat, it is reabsorbed by the body, and it deposits in the areas where there is increased sebum production, in areas where sebaceous glands are there. So as you can appreciate, there is yellowish discoloration over the skin, more prominent just around the nasolabial areas. And if you look at her eyebrows carefully, there is loss of the lateral part of the eyebrows. So hypothyroidism and carotenoderma are the two conditions that I was looking for in this answer.
Somik, can I just mention that cardiac tamponade is recorded but is distinctly uncommon in hypothyroid associated pericardial effusion. Rarely is it so large that it causes tamponade.
Yes, sir. That also is a very important message, that although some degree of pericardial effusion, which could even be moderate or huge, is quite common in overt hypothyroidism, untreated long-standing hypothyroidism, cardiac tamponade is something which is very uncommon in patients with hypothyroidism leading to pericardial effusion. So that also is an important learning, but that was what brought this patient to our attention. In this slide, you get to see two images. So this has a historical connotation and has a recent advanced connotation. So Giuseppe Marzo was the first reported case of congenital adrenal hyperplasia. It is said that he was born a female, was initially named Josephine, but very soon he was branded to be a boy. He was branded to be male and brought up as a male. He is said to have married a beautiful woman, but on the night of their marriage, the woman reportedly fled through the window. The next morning, he died of a supposed heartbreak, which according to modern endocrinologists was possibly an adrenal crisis. And crinecerfont, the molecule, is the very latest which has been tried in the treatment of congenital adrenal hyperplasia. It is a CRH1 antagonist, corticotropin receptor antagonist, and it reduces the levels of the androgens without being a glucocorticoid, without carrying the adverse effect of glucocorticoids. So the connection here would be congenital adrenal hyperplasia, which connects the image of this individual and the molecular structure of the chemical that we have put in here. What is being looked into, a subtraction scan tries to differentiate between a thyroid and a parathyroid SOL. So two other imaging procedures which also serve a similar purpose. One would be SPECT CT, not a simple SPECT, not a 2D technetium sesame scan, but a SPECT CT for anatomic localization. And the other investigation would be a 4D CT scan of the parathyroids. In a CT scan, in the unenhanced images, the parathyroid glands have a lower attenuation compared to the thyroid tissue to begin with, and parathyroid adenomas are known to rapidly enhance after contrast administration, and they rapidly wash out contrast as well, unlike thyroid nodules, which might retain them longer. Another differential here are lymph nodes, which take up contrast even more slowly, and the contrast washout is even more slowly there in lymph nodes when you are trying to differentiate between an ectopic parathyroid or a parathyroid gland in the neck and a lymph node. The answer we are looking for here is one, differentiating between a thyroid and a parathyroid lesion, and two, a SPECT CT and a 4D CT would be the other imaging procedures. If you put in an answer as MRI, that would not be correct because MRI has low sensitivity and specificity for differentiating between these two conditions. Question number 19. The image that you get to see here is of a physician called Dr. Jyoti Prakash Bose. We are in the 100th year of Dr. Alekya, if you could please mute yourself. We are in the centenary year of the discovery of insulin, and it's important that all of us get to know about this individual. Dr. Jyoti Prakash Bose was a physician working at Kolkata at the School of Tropical Medicine. So School of Tropical Medicine is the specific answer that I am looking here. In 1923, with the help of some of his friends who stayed at London, he could procure insulin, and he tried it in several children with type 1 diabetes, and he managed to publish successful case series of type 1 diabetes as well. The image here is that of a girl called Kumudini who was successfully treated with insulin that Dr. Jyoti Prakash Bose managed to use. He was the first Indian to use insulin, and the institution where he worked was the School of Tropical Medicine in erstwhile Calcutta.
And Shobik, you mentioned that the patient is also special. So what's special about her?
So about this patient, she was a published case. In fact, this patient did not receive insulin in 1923. But in 1923, Dr. Jyoti Prakash Bose actually used it in patients with diabetic ketoacidosis in the inpatient ward of the School of Tropical Medicine. I've put in this image because this is one of the earliest published images of type 1 diabetes being treated from India. This was a girl called Kumudini who was followed up by Dr. Jyoti Prakash Bose, and this is a publication in a medical journal from India, the earliest instance of a published case of type 1 diabetes being treated with insulin.
Fair enough. Yes, continue.
So the next question, 16-year-old girl, headache, neurosurgeon picked up a Cellar SOL, did a pre-op evaluation, found the cortisol to be a bit on the lower side, found the prolactin to be slightly high, referred to us. So the answer here would actually be a dilution. You need to do a dilution here to exclude a hook effect, because what you get to see here is actually a cystic prolactinoma. There's a big cystic area, but there's a lot of solid tissue there as well. And after dilution, actually, this individual had a very high prolactin value. So the next step here would be to do a proper dilution, at least a 1 in 100 dilution, to look for the hook effect, because this individual with a cystic prolactinoma would be a candidate for medical therapy rather than surgical therapy then. The additional step in the management of this individual would also be glucocorticoid replacement till the basal cortisol levels are somewhat higher, because as you can appreciate here, because of a compressive effect, she has secondary adrenal insufficiency at present. So the two steps that I was looking for are dilution and glucocorticoid replacement.
Should she also have estrogen or sex steroids, FSH, LH?
Yeah, that also would be important. That would be the next important step as well.
Yeah, okay.
So identify the intervention and identify the condition. The condition, as you can appreciate, a uniform enlargement, sort of symmetric enlargement of the pituitary gland with stalk thickening. It almost appears like a tent if you look at the upper surface of the pituitary. This is lymphocytic hypophysitis, which presents with headache in certain individuals. Within 2 weeks, decrease in size, decrease in headache with glucocorticoid administration. So the answers that I'm looking for here are lymphocytic hypophysitis and glucocorticoid administration. That's the intervention that was done here. Question number 23, 6-year-old girl. As you can appreciate, you get to see a precocious development of breast tissue. And if you look at the bone age corresponds to about 6 years. So precocious puberty without an advancement of bone age, the only diagnosis that we can think of is hypothyroidism. So this was actually pseudo precocity with breast enlargement without an advancement of bone age in this girl presenting with hypothyroidism. So the answer that I'm looking for here is hypothyroidism in this individual. Question number 24.
Primary hypothyroidism or secondary hypothyroidism?
So of course, primary hypothyroidism, that would be the specific answer that I'm looking for, given the mechanism of precocity. Question number 24, identify the disease here. If you look at the inheritance tree, you get to see that it's an autosomal dominant inheritance, which has been depicted here. If you look at the diabetes that this girl is suffering from, it's sort of a mild diabetes. The blood glucose values have never been very high. They have slightly been on the higher side, and she has responded to simple lifestyle modification for the past 5 years. Her mother, who didn't have diabetes otherwise, gave a history of gestational diabetes, and her grandfather has been detected with diabetes at an elderly age. So this typically fits into the pattern of maturity onset diabetes of young 2, MODY2, or glucokinase gene mutation. These individuals might develop diabetes at a very young age. It's usually mild and they respond to lifestyle modification. Women might only have gestational diabetes. If you look at the criteria for diagnosis of gestational diabetes, they might be fulfilling that, but might not have diabetes otherwise. In some individuals, it manifests at an elderly age because on top of the glucokinase gene mutation, glucokinase actually acts as a sort of a glucose sensor for the pancreatic beta cell. So it causes the beta cell to synthesize and secrete insulin in response to rising glucose levels. So with increasing age, since you have a decline in beta cell function as well, some of these individuals might present with diabetes at an increased age, and they might require treatment at that point of time, treatment with drugs at that point of time. So the answer that I'm looking for is glucokinase gene mutation or MODY2. Both these answers would fetch you full marks. The pathology that I was looking for here and the intervention, these were two parts of the question. If you look at this image carefully, this is a T2 weighted MRI image, and in a T2 weighted MRI image, the hyper intense areas with sort of a mixed intensity lesion with suprasellar extension point to the presence of a cystic craniopharyngioma. So this big area is a cyst here, the whitish part. These parts are the non-cystic areas. So mixed intensity mass with suprasellar extension. This is a cystic craniopharyngioma. The intervention that was done here is called a Ommaya reservoir system insertion. ORS in short, not oral rehydration solution, but Ommaya reservoir system or Ommaya reservoir, any one of these would do. An Ommaya reservoir is implanted in the subgaleal space beneath the galeal aponeurosis. It has a tube which connects to the cystic part of the craniopharyngioma, and you can use it to aspirate cystic fluid, which might accumulate in due course of time, thus not requiring repeated surgical interventions. So the two parts of the answer that I was looking for here are: one, the pathology here is a craniopharyngioma or a cystic craniopharyngioma. Both of these would fetch you marks. And the second part of the answer was a Ommaya reservoir implantation or Ommaya reservoir insertion. So identify the sign. The first case we discussed this evening was thyroid eye disease, and I think all of you appreciated the fact that the image on the left points to spindle-shaped thickening of the extraocular muscles, sparing the tendons, typical sign of thyroid eye disease. The outline that was made here refers to the indentation made on the medial wall of the orbit by the enlarged spindle-shaped muscles here. This part is a weak part. This is formed by a part of the ethmoid bone called the lamina papyracea. This is the weakest bony part of the orbit. Enlargement of the muscles here causes indentation here as sort of a pressure releasing mechanism, just as you have proptosis. And the sign, the name of the sign that I was looking for here is called the Coca-Cola sign or the Coca-Cola bottle sign. So while I was asking this question, Dr. Partho possibly said that the red color, and I said reddish brown, has something to do with the answer. So the answer that we were looking for here is the Coca-Cola sign or the Coca-Cola bottle sign. And the last question for Endocrine Hawkeye this year was image, a movie poster, a movie which was about the tragic life of jokers in the circus, and we know that most of them are suffering from achondroplasia. The latest approved drug for the treatment of achondroplasia is known as vosoritide, VOSORITIDE. Now, vosoritide is a C-natriuretic peptide analog, a CNP analog, which acts through a receptor known as NPRB, or natriuretic peptide receptor B. By acting through this receptor, it downregulates the action of FGFR23. FGFR23 is upregulated in achondroplasia, which leads to disruption of chondrocyte and bony growth. So by preventing this upregulation of FGFR23 and acting like a CNP analog, vosoritide exerts its action. So the two answers that I was looking for are vosoritide, and the mechanism of action is CNP receptor agonist analog. So with that, we come to the end of discussion of the answers of this year's Endocrine Hawkeye. I hope it was a nice learning session for all of you. In fact, some of the questions were quite difficult, but as Professor Chaudhuri was saying initially, a quiz is a fun way of learning. It's an innovative and a fun way of learning. So all of us should learn something new at the end of this session. To know the names of the winners of this quiz, you have to wait for a little over 17 hours. At 1:30 p.m. tomorrow, we'll be giving you the name of the winners of this year's Endocrine Hawkeye. And as we had said earlier, the winner will get the coveted title of Endocrine Hawkeye, besides a prize of 25,000 rupees. 15,000 rupees and 10,000 rupees are the prizes that will be given to the first and the second runners-up. Before we call it a day, I have an important task to do, which is to name the 5 finalists of the Endocrine Wise Owl for tomorrow. We had received around 30 entries for the Endocrine Wise Owl, where you had to do a critical analysis of a journal article. We had a difficult time selecting 5 entries out of those 30, but after a lot of intense scrutiny, we could find out 5 finalists who are Dr. Krishna Prabha from Christian Medical College, Vellore, Dr. Orijit Shingho from IPG MER and SSKM Hospital, Kolkata, Dr. Afsar Fatima from Narayana Medical College, Nellore, Dr. Johan Varghese from Andhra Medical College, and Dr. Abid Rasool from Sher-e Kashmir Institute of Medical Sciences, Srinagar. I'll read out the names once more. Dr. Krishna Prabha, Dr. Orijit Shingho, Dr. Afsar Fatima, Dr. Johan Varghese, and Dr. Abid Rasool. You will be mailed 5 different articles. Each of you will receive an individual article. You have to prepare a slide set, which you have to present over 4 minutes tomorrow. And you'll be asked questions on the basis of the slide set that you prepared on the article that you have been allotted. So with that, I think we have had a nice day's discussion, a day of academics, a day of learning, a day of experience and knowledge sharing. I would like to thank all our examiners who attended this session today and enriched us with their wisdom. I would like to thank all our students, all our participants who had joined in today, because without your participation, this program would lose its meaning. We'll meet tomorrow sharp at 9 a.m. I request all of you to join in at least 5 minutes early so that we can sort out any technical issues, if any. With that, I wish you a very good night. Stay safe, and we'll meet tomorrow in just over 12 hours time, around 13 hours time.
And really sincere thanks from my side to both Shomik, especially for sort of being there all through this last 5 hours and more, and also to Dr. Parthapratim Chakraborty, for both of you for being such wonderful quiz masters. Really, I hope all of us have learned something, will go back enriched at the end of this day. And of course, my personal thanks once again to all our faculty members and all of you who have joined in, our young friends. Thank you very much. Very good night. Meet again tomorrow morning.
Thank you, sir.